Hi students, welcome to this session which is FOCUS FMGE 2021 where I'll be discussing important questions of OBS and Gynae with you. And this session is especially for all the students who are going to give their MCI screening test, which is round the corner, but it is also useful for all those students who are going to appear for their NEET PG exam. Now, I have been getting many mails and many messages of the MCI students as to how I should be preparing OBS and Gynae, or messages asking me to tell you the important topics in OBS and Gynae for the MCI screening exam. So, bachcho, I just want that you give one entire day for OBGY now. Now, when you are giving that one entire day, what all are you going to do in that one day when you are going to prepare for the MCI exam, the upcoming MCI exam? See, if you go on the Marrow's YouTube channel, you will get a playlist. I want all of you to click on that playlist and it is going to appear something like this. In this playlist, I want you to click FMGE videos. Now, when you are going to click on FMGE videos, you are going to get 3 very important videos which I have given for all the FMGE students. That is revision and guidance session for FMGE OBS, revision and guidance session for Gynae for all the FMGE students, and instruments in OBS and Gynae. Now, these videos are very, very important, and these videos are roughly going to take 8 to 10 hours to complete. Then after that, I want all of you in the same playlist. This year, we had conducted a lot of webinars for FMGE students. Now, a recording of those webinars is still there on the YouTube channel, and you can go and look at important images in OBS for FMG exam. In this particular webinar, I have discussed with you all the important images related to labor, including partogram. Right? And there is one more session which I have taken that is the other important images in obstetrics. So if you do this much, plus if you do the set of around 30 questions which I will be discussing today, I think there are 30 or 35 questions which I'm discussing today. If you do this much in OBS and Gynae before you appear for your exam, I can guarantee you that around 80% of your questions will be from these sessions, right? So let's get going with the first question. The first question is, a pregnant client is making her first antepartum visit at 32 weeks of pregnancy. She has a 2-year-old son who was born at 40 weeks, a 5-year-old daughter who was born at 38 weeks, a 7-year-old twin daughters who were born at 35 weeks. She has had a spontaneous abortion 3 years ago at 10 weeks. Using the GT-PAL format, write the obstetrical score of the patient. Now, in the GT-PAL format, all of you know that G stands for gravida, where gravida is the number of times a female has conceived. And whenever we are talking about gravida, we include present pregnancy in gravida, right? So, in this case, this female, she had a 2-year-old son, number one. Then she has a 5-year-old daughter, then she has twin daughters, and she had an abortion, and now she's pregnant for the 5th time. So she is gravida 5, and all of the options which are given have gravida 5. Then T stands for the number of term pregnancies, and term pregnancies are defined as any pregnancy where delivery is happening between 37 weeks to 41 weeks plus 6 days, right? So, number of term pregnancies are now this one pregnancy which was 40 weeks, then 38 weeks, 2 pregnancies. The twin daughters, they were born at 35 weeks, and 35 weeks is a preterm pregnancy. It's not a term pregnancy, right? So, she is G5, term pregnancies is 2. P stands for the number of preterm deliveries, and all of you know the number of preterm deliveries. How do you define preterm deliveries? If delivery is happening at less than 37 weeks. Right, so in this case, she had twin daughters who were born at 35 weeks. So number of preterm deliveries, you are not going to say that because it is twins, it will be 2. Please remember that apart from this L, that is the number of living children, where twins are counted as 2, triplets are counted as 3, apart from that, in none of the other values, twins are counted as 2. Twins are taken as a single conception and a single delivery. It is only when we are talking about the number of living children, then we say that twins is counted as 2. right? So over here, the number of preterm is 1. A stands for abortion, and abortion is the, any pregnancy which is ending at less than 20 weeks, that is abortion. So over here, one pregnancy ended at 10 weeks. So A1, and L is number of living children at present. So at present, she has a 2-year-old son. She has a 5-year-old daughter. And I was telling you just now that in L, it is the twins will be counted as 2. So in number of living children, you have to count twin as 2. So it will be L4. So her obstetrical score is G5, T2, P1, A1, L4. So the correct answer is option C. Is that clear to all of you? In Gravida, you have to count the current pregnancy. When we are talking about term or whether we are talking about preterm, we are not going to count the present pregnancy. Only in Gravida, you have to count the present pregnancy, right? So that's a very, very important question. Next is, a client tells the junior resident on duty that the first day of her LMP was July 22nd, 2020. What is the estimated date of delivery? Now, whenever you have to calculate the estimated date of delivery, you have to use Negley's rule, and Negley's rule says that to EDD, you will have to add 9 months and 7 days, right? Now, 9 months should be added to whatever month they have given you. So, if you are adding 9 months to July, so August, September, October, November, December, January, February, March, April. So, you come to April. And whatever date is given to you, whatever is the date which is given to you, you will have to add 7 days, right? So, that is 29th April 2021. That is her expected date of delivery, right? The other very important thing is that how many females deliver on their exact EDD? What is the percentage? It's hardly 4% females who deliver on their exact EDD. 50% females, they deliver 1 week before or 1 week after their EDD. Now, suppose there is a female who comes to you, and this particular female, let's talk about her only. She comes to you on 29th of April and she says that, ma'am, you told that my EDD is 29th April, but I have still not delivered. What are you going to tell her? You are going to tell her that we can wait. And how much we can wait? We can wait up till 42 weeks. Right? So any pregnancy which is 42 weeks or beyond 42 weeks, so more than equal to 42 weeks is a post-term pregnancy. Right? So any pregnancy at 42 weeks or beyond 42 weeks is a post-term pregnancy, and any female who comes to you with a post-term pregnancy, what is the first step which you are going to do? Are you directly going to tell her that now you are post-term, I'm going to take you for induction of labor? No. Whenever a female comes to you with post-term pregnancy, the first step or the next step is that you have to first review her menstrual history. Many a times, females have either forgotten their LMP and that is why they are thinking that they are post-term, or it could be that the calculations were made wrong. So the first step whenever a female comes to you with post-term pregnancy is you have to review her menstrual history, and that's a very, very important clinical question, a clinical scenario which you have to keep in mind, right? Question number 3. All are true about Schultz's method of placental separation except. Now, but I am going to take those topics where you get confused, right? All those topics where you feel either less confident or you feel confused, I am going to take today's discussion only on those topics. We are not going to do simple questions. We'll be doing a lot of clinical questions or a lot of questions where you tend to get confused, right? So this is again one place where you tend to get confused. That is the Schultz method and the Duncan's method. So all of you know that there are 2 methods of placental separation. One is the Schultz method and the other is Duncan's method of placental separation. Now, in Schultz's method, please remember this is the more common method of placental separation, and here the separation of the placenta is going to begin from the center. Can you see? The placenta has started separating from the center. Now, because placenta starts separating from the center, so the retroplacental clot is formed, and because a retroplacental clot is formed, that is why amount of bleeding is less. And in this case, the bleeding is going to be present. It is going to come out. The blood is going to come out only once the entire placenta has separated. The last thing which you have to remember about Schultz method is that in Schultz method, see, this over here is the maternal side of the placenta and this is the fetal side of the placenta. So in case of Schultz method, it is the fetal side of the placenta which comes out first. Now let us look at the Duncan's method of placental separation. In Duncan's method of placental separation, the placenta starts separating from the periphery, and because it starts separating from the periphery, no retroplacental clot is formed and bleeding will be evident as soon as the placenta separates. Right? And because no retroplacental clot is being formed, that is why the amount of bleeding will be more in this case, right? And in this case, it is the maternal side of the placenta which is going to come out first. And how are you going to remember this? Please remember S for Schultz and S for shiny. So in case of Schultz method, it is the shiny fetal side of the placenta which comes out first. In case of Duncan's method, D for Duncan, D for dull. So it's the maternal side of the placenta which is dull. So in case of Duncan's method, it is the dull maternal side of the placenta which comes out first. Which of the two is more common? It's the Schultz method which is more common. Now look at this question. All are true about Schultz method of placental separation except option A, more common method of placental separation. Yes. Fetal surface comes out first. Yes. S for shiny, S for Schultz. So it's the shiny fetal side which comes out first. It is associated with less blood loss. Yes. Bleeding occurs before the placental delivery? No. Bleeding is going to happen once the entire placenta is delivered, right? So the incorrect option over here is option D. Now, in entire placenta, I know you remember every other thing about placenta. The one thing again which you tend to get confused in placenta is how is a placental barrier or a placental membrane formed. Please revise over here that from inside to outside, this is formed by number one, syncytiotrophoblasts, the placental barrier or the placental membrane. Then it is formed by cytotrophoblast. Then we have the extra embryonic mesoderm, and then we have the fetal capillary endothelium. So mother's blood is present in the intervillous space, and this is around 150 ml, whereas fetal blood is present in the villi, which is 350 ml, and maternal blood and fetal blood in the placenta are separated by placental membrane or placental barrier. And just now I have told you from inside to outside what are the layers of placental membrane or barrier. Right? So this is very, very important. The functional unit of the placenta is cotyledon. Again, a very, very important question. Right? Coming to the next question. A healthy 25-year-old G1P0. So gravida 1, parity 0. Now, exactly what do you mean by parity? Right? That was GT PAL score. What do you mean by gravida and what do you mean by parity? See, gravida means the number of times a female has conceived, including this pregnancy, right? Whereas parity means the number of previous pregnancies which have gone beyond the period of viability. So the number of previous pregnancies which go beyond the period of viability, that is what is parity. Right? In parity, you never include present pregnancy. Right? That's a very, very common mistake which all of you do. Please do not do that. Then what about the period of viability? The period of viability in India is 28 weeks. Right? Okay. So we have a healthy 25-year-old G1P0 at 37 weeks of gestation who comes to see you for a routine obstetrical visit. The patient complains to you that on several occasions she has experienced dizziness, lightheadedness, feeling as if she's going to pass out when she lies down on her back. So this patient is in her late third trimester, and when she lies on her back, she feels as if there is lightheadedness, there is dizziness, or she's going to pass out. Right? What is the most appropriate plan of management for this patient? So first you have to think that what are you dealing with? If there is a pregnant female who's lying supine and she gets feeling of dizziness, she gets hypotension, she feels as if she's going to pass out, this is a case of supine hypotension syndrome. Supine hypotension syndrome pe questions, bacho, they can come in the form of a clinical question like I just now told you, or they can show you this image. and they can ask you, what is this image indicating? So in this image, what I'm seeing in this image, I'm seeing that the gravid uterus is pressing on the inferior vena cava when a patient lies supine. So always remember that in the late third trimester, what happens is, if a female lies supine, a pregnant female lies supine, then her pregnant uterus presses on inferior vena cava, and because it presses on inferior vena cava, the venous return is decreased. And obviously, if venous return is decreased, cardiac output would be decreased. Now, when cardiac output will be decreased, it is going to lead to hypotension in the mother, and there will be decreased fetal blood flow also. Now, because there will be decreased fetal blood flow, so there can be fetal distress. That is why we always tell a female, a pregnant female, that she has to lie in the left lateral position and not in supine position. This is what is called as supine hypotension syndrome. So this particular female is experiencing supine hypotension syndrome, and what are you going to advise her? Option A, do an ECG. Option B, monitor her for 24 hours with Holter monitor to rule out arrhythmias. Option C, do an arterial blood gas analysis. Option D, reassure her and encourage her not to lie flat on her back. So I'm going to tell her not to lie flat on her back, rather to lie in left lateral position. Right? Clear to all of you? Then question number 5. Now this question number 5 is about the cardiovascular changes which occur during pregnancy. For your MCI exam, maternal adaptations in pregnancy is a very, very important topic. Please do not forget to revise that topic before you go for your exams, right? So you are called in to evaluate the heart of a 19-year-old primi gravida at term. Listening carefully to the heart, you determine that there is a split S1, normal S2, and S3 is easily audible, with 2/6 ejection systolic murmur, which is greater during inspiration. You immediately recognize which of the following, right? So you are hearing that S1 is split, S2 is normal, S3 can easily be heard, and you are getting an ejection systolic murmur, which is grade 2/6. Now, what all does this point to you? Option A, presence of S3 is abnormal. Option B, the presence of ejection systolic murmur is unusual at term. Option C, presence of both S3 and ejection systolic murmur is a significant abnormality. And option D, all findings recorded are normal changes in pregnancy. So as I told you, cardiovascular changes in pregnancy are very, very important. So let's quickly revise them. See, in cardiovascular system, you will have to understand there are certain things which are going to increase during pregnancy, and there are certain things which are going to decrease, and there are certain things, certain parameters which are going to remain normal in pregnancy, right? Now, in cardiovascular system, all of us know that cardiac output is equal to stroke volume into heart rate, and during pregnancy, all these three increase. Cardiac output increases, stroke volume increases, and heart rate increases. A very, very important question which is asked to you is that when is the cardiac output maximum? And this same question can be asked as, when are the chances of heart failure maximum in pregnancy? So the chances of heart failure are maximum immediately after delivery. If that is not given in the option, then the second best answer is second stage of labor. And if that is also not given, then the third best answer is 28 to 32 weeks of pregnancy, right? So best is that the cardiac output is maximum immediately after delivery. Second best answer is in the second stage of labor, and third best answer is between 28 to 32 weeks of pregnancy, right? Now, these are the parameters which increase in pregnancy. Now, all of you know that in pregnancy, the main hormone is progesterone, which is a smooth muscle relaxing hormone, and that is why peripheral vascular resistance decreases during pregnancy, right? So peripheral vascular resistance is going to decrease during pregnancy, and that is exactly the same reason why blood pressure decreases during pregnancy. A common mistake which you all do is you all think that only diastolic BP decreases during pregnancy, but please remember it's the diastolic, systolic, and the mean arterial pressure which is going to decrease in pregnancy. Very important point to note is that the jugular venous pressure or the central venous pressure, it remains normal in pregnancy. right? Apart from this, you have to remember that in pregnancy, S1 is loud and there is a wide split. S2 is normal and S3 is easily heard. During pregnancy, you get two kinds of murmurs, a continuous murmur and an ejection systolic murmur. This ejection systolic murmur is less than equal to grade 2/6. Right, so as long it is less than equal to grade 2/6, we say that it is physiological. So in our question, we are getting that S1 is widely split. We are getting S2 is normal. We are getting that S3 is easily heard. And we are getting that there is an ejection systolic murmur which is less than grade 2/6. So what does that mean? That means all the findings recorded are normal changes in pregnancy. Right? Clear to all of you? Okay. Going to question number 6. Physiological anemia in pregnancy, all are true except option A, it is due to hemodilution in pregnancy. Option B, it's microcytic in nature. Option C, it's normochromic in nature. And option D, hemoglobin always is more than equal to 11 gram per dl. So in order to understand this, you will have to understand the concept behind it. In other words, you will have to understand what are the hematological changes which are occurring in pregnancy. Now, again, in hematological changes, there are certain things which are going to increase and there are certain things which decrease during pregnancy. During pregnancy, the blood volume increases, and blood, as you know, is made up of a liquid component, that is plasma, and the cellular component, that is RBC, right? Now, during pregnancy, although plasma volume also increases and red blood cell volume increases, but the increase in plasma volume is much more than the increase in RBC volume. So, the liquid component of the blood is increasing more than the solid component, and that is why there is hemodilution in pregnancy. In other words, blood becomes thin in pregnancy, right? So, we can also say that the blood viscosity decreases in pregnancy. Not only does the blood viscosity decrease in pregnancy, hematocrit or packed cell volume also decreases in pregnancy. What is hematocrit? Hematocrit is the RBC volume upon the plasma volume. So RBC volume is also increasing and plasma volume is also increasing in pregnancy, but the increase in denominator is much more than the increase in numerator. That is why we say that hematocrit or the packed cell volume decreases during pregnancy. Now, because of this decrease in hematocrit, because of hemodilution, there is physiological anemia in pregnancy. And the characteristics of this physiological anemia is that in physiological anemia, never is hemoglobin less than 11 gram%. So whenever there is a female, so suppose there is a female whose before pregnancy, her hemoglobin was 12.6 and during pregnancy, it becomes 11.6. From 12.6, it has dropped and it has become 11.6. So I know it is a case of anemia, and because hemoglobin is above 11, I'll say it is a case of physiological anemia. But suppose there is a patient whose before pregnancy hemoglobin was 12.6 and during pregnancy it becomes 10.6. Now hemoglobin has become less than 11 gram%. So now I'm not going to call it as physiological anemia. Now it is called as pathological anemia or simply anemia in pregnancy. Right? So number one characteristic of physiological anemia is that hemoglobin remains always more than 11 gram%. Number two, this anemia is normocytic, normochromic in nature. Why I am telling you this is because if your hemoglobin is microcytic in nature, that means it is iron deficiency anemia and it is not physiological anemia. So yes, physiological anemia is due to hemodilution. It is normochromic in nature. Hemoglobin is always more than 11, but it is not microcytic. It is normocytic in nature. What is the most common anemia which is seen during pregnancy? It is iron deficiency anemia. What is anemia in pregnancy? Anemia in pregnancy means hemoglobin less than 11 gram%. Severe anemia means hemoglobin less than 7 gram%. And very severe anemia means hemoglobin less than 4 gram%. Right? Whenever a female is coming to you with severe anemia in late third trimester, the only, the option which you have is blood transfusion. right? So severe anemia patient coming to you in late third trimester, what is the management? Management is blood transfusion. Clear to all of you? Okay. Now, apart from these hematological changes, let us quickly revise the other hematological changes which occur in pregnancy. See, in case of pregnancy, because the RBC volume is increasing, so the amount of hemoglobin, that is the hemoglobin concentration, increases in pregnancy. The hemoglobin mass increases in pregnancy. So if someone asks you what happens to hemoglobin mass, which is measured in grams, you are going to say it increases in pregnancy because RBC volume increases in pregnancy, and that is exactly the reason why oxygen carrying capacity of blood increases during pregnancy. But if someone asks you what happens to hemoglobin concentration in pregnancy, that is measured in grams per DL, and the moment grams per DL comes, then we know that hemoglobin concentration decreases during pregnancy. The other important thing is WBC count increases in pregnancy, platelet count decreases in pregnancy, plasma protein increases in pregnancy, plus plasma protein concentration decreases in pregnancy. Globulins, they increase in pregnancy, albumin decreases in pregnancy, and this question they are going to ask you in the form of thyroid binding globulin. So what will happen to thyroid binding globulin in pregnancy? All globulins increase in pregnancy, so thyroid binding globulin will increase in pregnancy, and sex hormone binding globulin will also increase in pregnancy. See, all clotting factors increase in pregnancy except factor 11 and 13, and that is why pregnancy is called as a hypercoagulable state. Now, this question they are going to ask you by saying what happens to serum fibrinogen levels in pregnancy. Serum fibrinogen is clotting factor number 1. So, what happens to clotting factor number 1? All clotting factors increase in pregnancy except 11 and 13. So, you are going to say serum fibrinogen increases in pregnancy, and because serum fibrinogen increases in pregnancy, so ESR also increases in pregnancy. In hematological system, what are the things which remain normal in pregnancy? Bleeding time and clotting time, right? Okay. Let's go to quickly question number 7. A pregnant woman who's 7 weeks from her LMP comes to the office for the first prenatal visit. Her previous pregnancy ended in a missed abortion in the first trimester. So what is the reason for, most common reason for abortion in first trimester? The most common reason for abortion in first trimester is a germ plasm defect. That means a defect in the fetus, right? And what is that defect? That defect is aneuploidy. What do you understand by aneuploidy? Aneuploidy is a defect in chromosome number, right? If aneuploidy is not given to you, so the first best answer will be a germplasm defect. If germplasm defect is not given, then you're going to mark it as aneuploidy. If aneuploidy is also not given, you are going to mark the answer as trisomy. If trisomy is not given, you are going to mark your answer as monosomy X. And if monosomy X is not given, then you are going to mark your answer as trisomy 16. So please remember, if they ask you what is the most common cause of abortion, a single episode of abortion, whether it is happening in first trimester or whether it is happening in second trimester, your answer will be germplasm defect in this order. Germplasm defect, aneuploidy, then trisomy, then monosomy X, and then trisomy 16, right? Okay. Now, the patient, therefore, is very anxious about the well-being of this pregnancy. So, she's 7 weeks and she has one previous history of missed abortion. So, she's very anxious about the well-being of this pregnancy. Which of the following modalities will allow you to best document fetal heart? So, tell me, when can you listen to fetal heartbeat? By a Doppler. By Doppler, you can listen to fetal heartbeat by 10 weeks and by normal stethoscope between 18 to 20 weeks. Right? So at 7 weeks, can I listen to fetal heart sounds with a regular stethoscope? No. With a fetoscope? No. With a Doppler stethoscope? No. Now let us look on ultrasound when what signs of pregnancy are visible and at what time. So on ultrasound, the first sign which you get of pregnancy is a gestational sac. Gestational sac can be seen between 4 weeks, 3 days to 5 weeks on TVS. That means between 4.5 weeks to 5 weeks, you can see gestational sac on TVS. Between 5 weeks to 6 weeks, you can see a yolk sac, and cardiac activity can be heard by 6 weeks by TVS, right? So between 4.5 to 5 weeks, you can see a gestational sac, yolk sac by 5 to 6 weeks, and cardiac activity on TVS by 6 weeks. Anything which is visible on TVS will be visible earlier than on an abdominal scan. Everything on abdominal scan will be visible 1 week later than a TVS. So at 7 weeks, if I want to listen to the cardiac activity, the best thing is that I go for a ultrasound, and on ultrasound, best would be that I listen to it by a TVS. On TVS, everything would be visible and heard earlier than a TA. Right? So here the option given to you is transvaginal sonogram. So I'm going to do a transvaginal sonogram. Clear to all of you? Okay. Next question. A 29-year-old Caucasian primigravida is 20 weeks pregnant with twins. Right? She found out today on a routine ultrasound for fetal anatomy that she is carrying 2 boys. So all of you know that in India that yes, the sex cannot be revealed on ultrasound, but it is not so in developed countries like US and UK where the sex is revealed once the ultrasound is done. So this female who's 20 weeks pregnant, she has come to know that she's carrying twins and both of them are boys. In this patient's case, which of the following statements about her twins is true? Right? So you have to tell which is true. Option A, the twins must be monozygotic since both are males. Option B, if the division of these twins occurred after the formation of the embryonic disc, the twins will be conjoined. Option C, she has higher incidence of having monozygotic twins since she is a Caucasian. Option D, if the ultrasound showed 2 separate placentas, the twins must be dizygotic. So you have to tell which statement is true. And so that you understand what these statements means, let us quickly see what are dizygotic twins and what are monozygotic twins. See, all of you know if there are 2 separate ova which are fertilized by 2 separate sperms and 2 separate zygotes are formed, that is a dizygotic twin. And if there is a single ova which is fertilized by a single sperm and a single zygote is formed and then that zygote divides into 2, then that's a monozygotic. The other very important thing is dizygotic twins are more common and monozygotic twins are less common. Right? Now, in case of dizygotic twin, each zygote will form its amnion and each zygote will form its own chorion. Right? So, always dizygotic twins are dichorionic, diamniotic. Now, I am telling you that the most common variety of twins is dizygotic and dizygotic are always dichorionic, diamniotic. So, if I ask you which is the most common variety of twins, you will always say most common variety is dichorionic, diamniotic, right? But this is not the case with monozygotic twins. In case of monozygotic twins, whether they are developing their own chorion or amnion or not, that depends upon at what time is the division happening. If division is happening at less than equal to 3 days, then you get dichorionic, diamniotic twins, right? If division is happening between 4 to 8 days, you get monochorionic diamniotic twins. If division is happening between 8 to 12 days, you get monochorionic monoamniotic twins. And if division is happening at more than equal to 12 days, then you get conjoined twins, right? So over here, one option was, okay, just now let's not talk about the options. Let's see here. So if I say that if you are getting dichorionic twins, see dichorionic twins, then they can be dizygotic or they can be monozygotic. As you can see here, that dichorionic, they can be dizygotic because dizygotic are always dichorionic, and they can also be monozygotic if division is happening at less than 3 days, right? But monochorionic are always monozygotic, right? Monochorionic will always be monozygotic. This much is clear to all of you, right? Now, dizygotic there are 2 different ova which are being fertilized by 2 sperms. So, 2 different zygotes are formed. Now, it could be that both these zygotes have the same sex, or it could be that they have different sex. In case of monozygotic twins, it's a single zygote which is dividing into 2. So, always monozygotic will have the same sex. In other words, if I am getting same sex Can I say that they will always be monozygotic? No, because same sex can be dizygotic, can be monozygotic. But on the other hand, if I am getting different sex, then 100% it means they are dizygotic. Different sex can never happen in monozygotic, right? Then, the next very important point is that incidence of dizygotic twins, it varies from country to country. Whereas the incidence of monozygotic twins is same throughout the world, and that is 1 in 250 pregnancies. That is 4 in 1000 pregnancies, right? Now, let's talk about placenta. Now, because in dizygotic twins, there are 2 ova, 2 sperms, 2 zygotes, so always there will be 2 placentas. Whereas in monozygotic twins, if they are dichorionic, diamniotic, there will be 2 placentas. If they are monochorionic, there will be single placenta, right? So that means if you are getting double placenta, can you say that it always has to be dizygotic? No. Because even in monozygotic, if the division is happening at less than 3 days, they are dichorionic diamniotic, and dichorionic diamniotic means that they will have 2 different placentas. So presence of 2 different placentas does not mean that it is a case of dizygotic. Clear to all of you, right? And the last thing before I go to that question is that always the prognosis depends on chorionicity. Prognosis does not depend upon zygosity, right? So prognosis will not depend upon whether the twins are dizygotic or monozygotic. Prognosis is going to depend upon whether the twins are dichorionic or whether the twins are monochorionic. Why? Because there are certain complications which are more common in monochorionic twins which are never seen in dichorionic twins. Right? So as an obstetrician, it's always very important for me to know the chorionicity rather than the zygosity. And for chorionicity, the best investigation is ultrasound, which should be done between 11 to 14 weeks. In case of dichorionic twins, twin peak sign will be positive. Please remember, di for means 2 and twin peak means 2. So dichorionic twins may twin peak sign is positive. In monochorionic twins, the twin peak sign is negative. Right? That's one thing. Number 2, in dichorionic twins, you are going to get 4 membranes in between the fetus. In monochorionic twins, this is not the case. In monochorionic diamniotic twins, there are 2 membranes in between the fetus, whereas in monochorionic monoamniotic twins, there is no membrane between the fetus. Right? So there is no time that I can explain you this. This I have explained very well in the lecture which I have given, video of twin pregnancy on marrow. But over here, if you have not watched that video and you do not have time to follow it, then in that case, just remember this much, that in dichorionic diamniotic twins, there are 4 layers of membranes between the twins. In monochorionic diamniotic, there are 2 layers of membranes, and in monochorionic monoamniotic, there is no membrane in between the twins. Clear to all of you? So with this background, let's go back to the question. So this female has 2 boys, right? That is all what they have come to know. They have not commented upon chorionicity. They have not told us whether twin peak sign is positive or not. They have just told us that there are 2 boys. So now you have to just tell that what is the statement which is true. Option A, the twins must be monozygotic because they are males. No, because same sex can be seen in dizygotic twins. Option C, we'll talk about option B later. Option C, she has higher incidence of having monozygotic twins since she is a Caucasian. No. Just now I told you that the incidence of monochorionic twins is same throughout the world, and that is 1 in 250 pregnancies. It is the incidence of dizygotic twins which varies. So since I cannot, over here they are talking about monozygotic twins, so this statement is wrong. Then if ultrasound showed 2 separate placentas, then the twin must be dizygotic. Again, that's incorrect. Just now I told you that if 2 separate placentas are seen, that simply means they are dichorionic. And dichorionic could be seen in dizygotic, or they could be seen in monozygotic if the division is happening at less than 3 days. So option D is also incorrect. Now, Go to option B. If division of these twins occurred after the formation of embryonic disc, and that means we are talking about conjoined twins. So if division is happening at more than equal to 12 days, in other words, after the formation of embryonic twins, then after the formation of embryonic disc, then it results in conjoined twins. That's very true, right? So the correct statement over here is option B, right? Coming to question number 10. A G2P1 at 28 weeks with twin gestation undergoes ultrasonography. The sonogram indicates that the fetuses are both male and chorionicity is monochorionic diamniotic, right? Now tell me, in monochorionic diamniotic, is the twin peak sign, will it be seen? No, twin peak sign would be absent. How many membranes will there be between the twins? There will be 2 layers of membranes between the twins. Okay. Now, I was telling you in the previous question that in monochorionic twins, the prognosis is bad. In dichorionic twins, the prognosis is good because there are certain complications which are seen in monochorionic twins which are not seen in dichorionic twins, right? So, in case of monochorionic diamniotic twins, you see twin-to-twin transfusion syndrome. What happens in this case? In this case, there is a vascular connection between the twins such that blood flows only in one direction. So the twin which is giving its blood becomes the donor twin and the twin which receives its blood becomes the recipient twin, right? Now, let's look at this question. Over here, they are saying twin B is noted to have oligohydramnios and is much smaller than twin A. That means twin B is smaller and it has oligohydramnios. That means twin B is your donor twin, right? Now, they are asking which of the following would be a finding most likely associated with twin A. So, what complication are you going to see in twin A? Right? So, in twin-to-twin transfusion syndrome, one of the twin becomes a donor twin, the other twin becomes a recipient twin. In the donor twin, the hemoglobin will be less. In the recipient twin, hemoglobin will be more. Right? In the donor twin, you are going to get oligohydramnios. Whereas in the recipient twin, you are going to get polyhydramnios. Why? Because in the recipient twin, there will be more blood flow. So if there will be more blood flow, more blood will go to the fetal kidneys. And so there will be polyuria and that will lead to polyhydramnios. The reverse is going to happen in donor twin, right? Now, because in donor twin, there is decreased blood flow, so it can lead to complications like renal failure. In case of recipient twin, there is increased blood flow and increased blood flow can lead to congestive heart failure and because they have more hemoglobin, right, they add more blood flow, so there are increased chances of thrombosis, right? Then in case of donor twin, the growth will be less. In case of recipient twin, growth would be more. Have you understood the complications which can happen in donor twin? Anemia can happen in donor twin, IUGR can happen in donor twin, oligohydramnios can happen in donor twin, and renal failure can happen in donor twin, right? In recipient twin, you will get more growth of the baby, you will get more hemoglobin, and that can lead to thrombosis, there can be congestive heart failure, and there will be polyhydramnios. Please remember that for diagnosis of twin-to-twin transfusion syndrome, the most important 2 criteria are that the twins should be monochorionic diamniotic, number 1 criteria, and number 2 criteria is one of the twins should be having oligohydramnios and the other should be having polyhydramnios. These are the 2 criteria for recognizing twin-to-twin transfusion syndrome. Now, in our question also, the twins are monochorionic diamniotic and they are saying that twin B has got oligohydramnios. Now, which is the donor twin? They are asking you in case of recipient twin, which is your twin A, what complication will you see? Will you see congestive heart failure? Yes. Anemia? No. Anemia will be seen in donor twin. That is twin B. Hypovolemia? No. Hypotension? No. Low amniotic fluid level? No. So, in case of twin A, which is the recipient twin, you are going to get congestive heart failure. Right? Okay. Now, very important thing, please remember that in monochorionic twins, we have monochorionic diamniotic and we have monochorionic monoamniotic. The complication which is seen in monochorionic diamniotic more commonly is twin-to-twin transfusion syndrome. The complication which is seen in monochorionic monoamniotic. So over here, this is one twin, this is another twin. This is their chorion and this is their amnion and this is their chorion. Monochorionic, monoamniotic. Now both the twins have a single chorion and a single amnion, and here are their umbilical cords. So what complication can happen in monochorionic, monoamniotic twins? Cord entanglement. That's a very, very important complication of monochorionic, monoamniotic twins, and that is why in monochorionic, monoamniotic twins, you always have to do a cesarean section between 32 to 34 weeks. Similarly, a cesarean section has to be done in conjoined twins, and this is very oftenly repeated question that in monochorionic, monoamniotic twins, what is the route of delivery and what time do you deliver them? So you are going to do a cesarean section between 32 to 34 weeks because of complication like cord entanglement, right? Next question, question number 11. A healthy 20-year-old G1P0 presents for her first obstetrical visit at 10 weeks of gestation. She denies any significant medical history, both personal and in her family. Which of the following test is not a part? So which of the following test is not a part of the recommended first trimester blood testing for this patient? So here we are talking about antenatal visits, which is again a very, very important topic as far as your MCI exam is concerned. Please remember that the ideal number of antenatal visits are between 12 to 15. That's very important. But as per Government of India, the minimum number is 4, whereas the ones which are recommended by WHO are 8. Right? So ideal 12 to 15 by the Government of India, it is 4, and by WHO, the minimum number which is recommended is 8. Now, what do you do in the first visit? Which investigations do you do? Number 1, you are going to check for hemoglobin. Hemoglobin has to be checked in the first trimester and it has to be repeated in each trimester. You have to check for ABORH, that is the blood group of the patient. You have to do a urine routine microscopy. Urine routine microscopy has to be done at every visit. Why? Because one of the very important causes of preterm labor is asymptomatic bacteriuria. So in every visit, you have to do a urine routine microscopy. Then you have to check for viral markers and infection markers, like you have to do a VDRL, you have to do HIV and HBsAg. Then as per the guidelines of India, that is DIPSI, you have to check their blood sugar levels and you have to repeat it between 24 to 28 weeks of pregnancy again. And the blood the sugar test which we do in pregnancy as recommended by DIPSI or as followed by the Government of India is a 2-hour OGTT. So you have to do a 2-hour OGTT in the first antenatal visit, and then you have to repeat it between 24 to 28 weeks of pregnancy. In some centers, facility for TSH is also available, and definitely if your patient can afford it, you have to get a TSH done. Apart from these, some special set tests which you are going to tell a female to get done if she can afford it are, you have to tell them to get a screening for Down syndrome done, and a rectovaginal swab testing has to be done at more than equal to 36 weeks, right? This is for detecting group B streptococci infection. So this is the order in which you have to do. In the first antenatal visit, you have to do all these tests, and in between more than equal to 36 weeks, you have to go for a rectovaginal swab. As far as ultrasounds are concerned, you are going to get an ultrasound done in the first trimester, and that is called as a dating scan. Right? Because it is in the first trimester when you get an ultrasound done, it tells you best about the gestational age or the period of pregnancy. If they ask you that for knowing the gestational age or for knowing the period of pregnancy, which is the best ultrasound marker, then the best ultrasound marker is crown rump length overall. But if they ask you specifically trimester wise, then in first trimester it is crown rump length, in second trimester it is biparietal diameter, and in third trimester it is femur length. But overall, it is the crown rump length, which is the best ultrasound parameter for knowing the gestational age. Then an ultrasound has to be done in second trimester, which is called as the booking scan, or it is the target, it is the anomaly scan, and this has to be done between 16 to 20 weeks. This is a level 2 ultrasound which is going to screen a fetus from top to bottom for all the fetal anomalies. Now, if during pregnancy only one ultrasound has to be done, then it has to be an anomaly scan. It has to be done in all pregnant females between 16 to 20 weeks. Then ultrasound is done in third trimester, that is called as growth scan. And in order to know about the growth, to know whether the fetus is growing properly or not, the best thing is that we use Hadlock's formula. Right? So best way of knowing about the fetal growth is by using Hadlock's formula on ultrasound. But if that is not given in the option and they ask you a parameter, then the best ultrasound parameter which tells you about fetal growth is abdominal circumference. Right? So these three ultrasounds are essential, in which first trimester ultrasound tells you about the period of gestation. Second trimester ultrasound is level 2 scan, which tells you about the anomalies in the fetus. But that does not mean that the first trimester ultrasound cannot tell you about the anomalies. There are certain anomalies which can be detected in first trimester, please remember. And these are the neural tube defects. They will ask you two questions over here. One question would be that anencephaly can be earliest detected on ultrasound at. So anencephaly can be earliest detected on ultrasound at 10 weeks. Next question, they will ask you what is the best time for detecting anencephaly on ultrasound. Then you are going to say it's more than equal to 14 weeks. Right? And so these are the questions which they are going to ask you on ultrasound. Now they are asking you this question that this female has come to you for her first antenatal visit. Which investigations are you going to do except, right? So which is not a part of the routine first trimester blood testing. Option A, CBC. Option, so CBC I'm going to do. Option B, screening for HIV. Option C, quadruple test. Option D, 2-hour OGTT. 2-hour OGTT I am going to do. Right? Quadruple test. Quadruple test is a test for Down syndrome screening. And this is done in second trimester. This is not done in first trimester. For first trimester in Down syndrome, here patient is coming to you at 10 weeks. You will do a dual test, and in dual test you are going to look at PA, PPA and HCG levels. In second trimester, I go for a quadruple test, and in quadruple test we look for alpha fetoprotein, HCG, unconjugated estrogen and inhibin. Right? So quadruple test is not a part of routine first trimester tests which you are going to do in the antenatal visit. Right? Then question number 12. A primigravida female undergoes her 2-hour OGTT at 12 weeks of pregnancy, and her 2-hour PPBS value is 222 milligrams per DL. In such a patient, the next step in management is. So as I told you that whenever a patient comes to you in the first trimester, in the first antenatal visit, you have to do her 2-hour OGTT as per the Government of India guidelines or as per the DIPSI guidelines. What do you do in this test? In this test, first thing what you have to remember is fasting is not mandatory. So irrespective of the previous meals of the pregnant female, you are going to give her 75 grams of oral glucose and you are going to mix it in 250 ml of water. Right? And you are going to tell her that she has to drink this entire glucose mixed water in 10 minutes. And after that, you are going to check her blood sugar levels after 2 hours. Right? So you are going to check her blood sugar levels after 2 hours. Because you are checking her blood sugar levels after 2 hours, this is called as 2-hour OGTT test. But please remember, fasting is not needed for this test. Right? Now, after 2 hours, if her blood sugar levels are less than 140, that means it is normal, right? You can remember one more thing over here, that if it is between 120 to 140, we call it as deranged glucose tolerance. If it is between 120 to 140, but if you don't even remember that, that's okay. If it is less than 140 and you remember this much that it is normal, it's okay. Right? Now, if the levels are between 140 to 200, then that means she's a case of gestational diabetes. Right? Gestational diabetes, what does that mean? That means the diabetes is developing during pregnancy because of insulin resistance. right? But if her values are more than equal to 200 milligrams per DL, that means she's a case of overt diabetes or pre-gestational diabetes. What do you mean by that? That means she had diabetes even before pregnancy. Gestational diabetes means that she did not have diabetes before pregnancy, only during pregnancy because of insulin resistance she's developed diabetes, right? So our patient's 2-hour ppbs value is 222 milligrams per DL. That means she's a case of overt diabetes, right? Or pre-gestational diabetes. Now they are asking you how you are going to manage her. What is the next step in management? Option A, start MNT alone for 2 weeks. Now first tell me, what is MNT? MNT is medical nutrition therapy. Medical nutrition therapy, which you commonly called as diet modification. So diet modification is called as MNT. So are you going to give her diet modification for 2 weeks? Are you going to start diet modification and insulin? Are you going to start diet modification and metformin? Or you are going to do nothing and you're going to repeat the test between 24 to 28 weeks? Please remember that this test which you are doing is a screening as well as confirmatory test. There is no other test which you have to do if once your values are raised. So option D is totally gone. I'm not going to repeat the test. I am going to take it as that this is an abnormal test and this patient is suffering from overt diabetes. Now, whenever you have a patient of overt diabetes, what is the treatment? See, as far as management of overt diabetes and gestational diabetes is concerned, there are few common things. The common things are, to both these category of patients, you have to advise them weight counseling, number one. You have to advise them MNT, that is diet modification, right? In case of overt diabetes, along with diet modification, immediately you have to start insulin. Are you understanding? So in case of overt diabetes, it is not just diet modification we tell them diet modification plus insulin, which is the drug of choice for treating diabetes in pregnancy, right? Now, if it is a case of gestational diabetes, then I am going to start MNT alone for 2 weeks. Only diet modification for 2 weeks if it is a case of gestational diabetes. And I am going to aim that with diet modification, her fasting blood sugar levels should come less than 95, her 2-hour PP levels should come less than 120, and her HbA1c should come less than 6%. This is my aim. But if these goals are not achieved by diet modification alone, after 2 weeks, I am going to start insulin. Is that clear to all of you? So in gestational diabetes, initially you give diet modification alone for 2 weeks. And if these goals are not achieved, then you put the patient on insulin. In case of overt diabetes, immediately you have to put the patient on insulin and diet modification. The other thing which you have to keep in mind is that the drug of choice for diabetes in pregnancy is always insulin, right? But suppose in case of gestational diabetes, patient is non-compliant. Then only in case of gestational diabetes, if there is a non-compliance to insulin, you can replace insulin with metformin. You can never give metformin in case of overt diabetes, right? In overt diabetes, there is just one treatment, MNT plus insulin, right? Okay. So over here, start MNT alone for 2 weeks, start MNT and insulin. That's the best answer. You are not going to give metformin and you are not simply going to give diet modification alone, right? Next question. A 28-year-old G1 presents to your office at 8 weeks gestation. She has history of diabetes since the age of 14. That means she's a case of pre-gestational diabetes. Right? She uses insulin and denies any complications related to her pregnancy. Which of the following is the most common birth defect associated with diabetes? So just now I told you that there is a difference in management of both these diabetes. Now I'm going to tell you there are some other differences which are there in overt diabetes and gestational diabetes, in which the most prominent difference is that gross congenital anomalies. Gross congenital anomalies, the risk of gross congenital anomalies in the fetus is increased in case of overt diabetes. It is not increased in case of gestational diabetes. Why? Because gestational diabetes happens due to insulin resistance, and insulin resistance is seen before around 24 to 28 weeks of pregnancy, and by that time organogenesis is complete. So gestational diabetes होने का जो most common time होता है, that is around 24 to 28 weeks of pregnancy. That means it is seen in second and third trimester. Whereas overt diabetes का मतलब है that there is a diabetic patient who has conceived. So a diabetic patient who has conceived, that means diabetes is going to be seen in first trimester, second trimester and third trimester. And because it is seen in first trimester, overt diabetes, and because please remember that hyperglycemia is fetotoxic. So in case of overt diabetes, if the blood glucose levels of the patients are not controlled, definitely it leads to increased chances of congenital anomalies in the fetus. When I say congenital anomalies, it means congenital anomalies or birth defects only. Congenital anomalies and chromosomal anomalies are not the same, right? So the risk of chromosomal anomalies is not increased in them. In either of these categories, the risk of chromosomal anomalies is not increased. It is the risk of congenital anomalies which is increased. That is the structural defects which is increased, not chromosomal defects, right? So congenital defects are increased in case of overt diabetes, not in case of gestational diabetes. Chromosomal anomalies are not increased in both of them, right? Now comes to very important question that if congenital defects are seen in overt diabetes, which is the most common system which is involved? Most common system which is involved in the fetus is the cardiovascular system, followed by central nervous system. The most common congenital anomaly will be ventricular septal defect. If that is not given in the options, then neural tube defects. If they ask you most specific, be very, very careful. If they are asking you most specific, then most specific and most common are not the same. Most specific is sacral agenesis, which is also called as caudal regression syndrome. Similarly, if they ask you most common cardiovascular defect, it is VSD. But if they ask you most specific cardiovascular defect, then that is transposition of the great arteries. Right? So over here, they're asking you, which of the following is the most common birth defect associated with diabetes? Options are option A, anencephaly, option B, encephalocele, option C, meningomyelocele, option D, sacral agenesis, option E, VSD. Just now I told you VSD is more common than neural tube defect. So the answer over here will be VSD. If the same question would have been asked and the question would have been most specific, then in that case, what would the answer be? Then in that case, the answer would be sacral agenesis. Just now the question is most common, so the answer is VSD. Clear? Okay. Question number 14. False about vaccination in pregnancy. Option A, 2 doses of TD vaccine are given to a pregnant female. First dose to be given in the first antenatal period. Option B, 2 doses of TD vaccine are given to the pregnant female. First dose to be given at 20 weeks. Option C, pregnant females with complete TD vaccination within 3 years need only 1 shot of TD vaccine. Option D, in current COVID epidemic situation, it is advisable to give flu shot to a pregnant female anytime during pregnancy. So you have to tell me false statement about vaccination. Please remember that these days it is not TT. It is not tetanus toxoid which we are giving. These days the vaccination which we are giving is TD. That is tetanus plus diphtheria toxoid, and this TD vaccination, it has to be given in the first antenatal visit, and the second dose has to be repeated after 4 weeks, right? But suppose if your patient has had complete vaccination in the past 3 years, anytime during the past 3 years she has had already a complete vaccination course, then during pregnancy she has to take only 1 dose of TD. Right? Then it is not necessary that she has to take 2 doses of TD. Right? The other thing which you have to remember is WHO is saying that in those countries where Tdap is available, suppose Tdap is available, which is not available in India, but if Tdap is available, which is tetanus plus diphtheria plus pertussis, then you have to give only 1 dose, and this 1 dose should be given between 27 to 36 weeks. Then it is not necessary that you give TD1 and TD2. So suppose if TD is not there in your questions, they ask a question about Tdap. Then please remember Tdap is given only once in pregnancy between 27 to 36 weeks. Right? Clear to all of you? The next important thing is that as of now, COVID-19 vaccination is not recommended by Government of India for pregnant females. But as far as flu vaccine is concerned, it is being said that to all pregnant females, a shot of flu vaccine should be given in COVID epidemic anytime during pregnancy. So anytime during pregnancy, I have to give a flu shot to the patient, to a pregnant female, and I have to give her 2 doses of TD, TD1 and TD2. TD1 has to be given in the first antenatal visit, and after 4 weeks, I have to give her TD2. So over here, option B, which was saying that 2 doses of TD vaccine are to be given, first dose at 20 weeks is wrong. Earlier it was said that 20 weeks, but now it is said that you have to give it at the first antenatal visit, right? Clear? Okay. So coming to the next question, all of the following statements are true with respect to a normal pregnancy except option A, dose of folic acid to prevent recurrence of neural tube defect is 0.4 mg per day. So they are asking dose of folic acid to prevent recurrence of neural tube defect is 0.4 mg per day. In Anemia Mukt Bharat program, the red pill has 60 milligrams of elemental iron and 500 micrograms of folic acid. Option C, increased caloric requirement in pregnancy is 350 kilocalories per day. And option D, no increased calories are needed in first trimester of pregnancy. So please read your questions very, very carefully. The question is about all are true except, right? So always remember that whenever folic acid is given to prevent neural tube defects, then you have to give it before conception, right? And in order to prevent anemia, you have to give it from 4th month of pregnancy. So here our target is we have to prevent neural tube defects. Now, in order to prevent neural tube defects, there are 2 things which you have to remember. If your question is saying that they want to prevent neural tube defect, what is the dose and when it should be given? So in order to prevent neural tube defects, the dose of folic acid is 400 micrograms, which is equal to 0.4 mg per day. And it should be given preconceptionally 1 month before pregnancy, and it should be continued for 3 months after conception. And this is the dose which has to be given to all pregnant females. Right? This is to prevent neural tube defect. Now, suppose your question is saying to prevent recurrence of neural tube defect. Prevent recurrence of neural tube defect means that this patient already had a neural tube defect in a previous pregnancy, right? So if there is a pregnant female who already has a history of neural tube defect in previous pregnancy, then the dose is not 400 micrograms, then the dose is 4 milligrams per day. And it should be given preconceptionally as soon as she plans pregnancy. As soon as she thinks about pregnancy, you have to give her 4 milligrams per day. And again, it has to be continued for 3 months after conception. Clear to all of you? So to prevent neural tube defect, the dose is 0.4 mg. But to prevent recurrence of neural tube defect, that means in a pregnant female who already has history of neural tube defect baby, then the dose is 4 milligrams per day. Now the confusion comes when they are talking about that there is a pregnant diabetic female, what is the dose of folic acid in them? So in a pregnant diabetic female, we are not talking about history of neural tube defects. We are just talking about a pregnant diabetic female. So in pregnant diabetic female, the dose of folic acid is 400 micrograms per day. In a pregnant female who is on anti-epileptic drugs, now this is an update. Any pregnant female who is on anti-epileptic drug, now the dose of folic acid is 400 micrograms as per ACOG. As per some other groups, it is 1 milligram per day, but it is never more than 1 milligram per day. Right? So earlier we used to say that if patient is on anti-epileptic drug, then also the dose of folic acid is 4 milligrams per day. So in the marrow notes also you would have read it as 4 milligrams per day. But this is an update that ACOG now says that the dose is 400 micrograms even if patient is on anti-epileptic drug. Some other groups say it is 1 milligram per day. Right? But never more than 1 milligram per day. Right? Now let's talk about Anemia Mukt Bharat program. In Anemia Mukt Bharat program, there is a red pill, and that red pill has got 60 milligrams of elemental iron and it has got 500 micrograms of folic acid. This is the red pill is given to prevent anemia in pregnancy. So it has to be given to all pregnant females to prevent anemia. This is not the dose to treat anemia. So to prevent anemia, you have to give them 1 pill per day, which has to start from 4th month of pregnancy, and it has to be continued for 180 days of pregnancy. And 180 days of pregnancy starting from 4th month actually means you have to continue it throughout pregnancy and for 180 days after delivery. Right? Now, this is for preventing anemia. Now, as I told you, to treat anemia, this is not the dose. To treat anemia, the dose is 2 pills per day. Right? And I also told you if there is severe anemia in the later third trimester, in the second half of third trimester, then the treatment of choice is blood transfusion. Right? Now, what are the extra calories which are needed in pregnancy? The extra calories which are needed in pregnancy are 350 kilocalories per day. During lactation, it is 600 kilocalories per day. Trimester wise, you have to remember that in first trimester, no extra calories are needed. In second and third trimester, yes, extra calories are needed. As far as iron is concerned in pregnancy, the total amount of iron which is needed in pregnancy is 1000 milligrams. Out of this 1000 milligrams, fetus needs 300 milligrams. So per day, the amount of iron which is needed by a pregnant female is 4 to 6 milligrams per day. If we divide it trimester wise, in the first trimester, it is 1 to 2 milligrams per day. In the second trimester, it is 4 to 5 milligrams per day. And in the third trimester, it is 6 milligrams per day. Right? So this is what is the iron requirement which are there in pregnancy. So with this background, look at this question again. So they are saying dose of folic acid to prevent the recurrence of neural tube defect. To prevent the recurrence of neural tube defect, the dose is not 0.4 mg per day. It is 4 milligrams per day. Right? Anemia Mukt Bharat program, this is right, and this is right. Next question. Question number 16. A 19-year-old G1P0 presents to her obstetrician's office for a routine obstetrical visit at 32 weeks of gestation. Her pregnancy has been complicated by gestational diabetes requiring insulin for control. She has been non-compliant with diet and insulin therapy. She has had 2 prior normal ultrasound examinations at 20 weeks and 28 weeks. She has no other significant past medical or surgical history. During the visit, her fundal height measures 38 centimeters. So she is 32 weeks pregnant. She is a case of gestational diabetes and her fundal height is 38 weeks. Right? That means height of the uterus is more than the period of gestation. Now, what are the conditions in which height of the uterus is more than the period of gestation? Number 1 is wrong dates. Right? Number 2 is twin pregnancy. Number 3 is polyhydramnios. Number 4, if there is a big fibroid. Number 5 is it could be a case of macrosomia. Then also the height of the uterus will be more than the period of gestation. And in early weeks of pregnancy, it could happen because of molar pregnancy. So these are, and please remember that one other cause is a full bladder. So whenever you are, as a patient, as a doctor, whenever you are measuring fundal height, you always have to tell your patient to evacuate the bladder. Right? Now they are asking you which of the following is the most likely explanation for the discrepancy between fundal height and gestational age. Now tell me, this patient, she had got her ultrasound done at 20 weeks and 28 weeks and everything was normal. So if everything was normal, could it be a case of fetal hydrocephaly? Because if it would have been a case of fetal hydrocephaly, then it would have been seen or detected or diagnosed at 20 and 28 weeks. Her 20 and 28 weeks ultrasounds are absolutely normal. It cannot be a case of fibroids because again it would have been seen in ultrasound at 20 to 28 weeks. Undiagnosed twin gestation is highly unlikely because she got an ultrasound done between 20 to 28 weeks. All of a sudden it will not happen that twins will be detected. Right? So that means it is a case of polyhydramnios, and all of us know that one of the very important reasons for polyhydramnios is maternal diabetes, and this patient is a case of maternal diabetes, right? So what is polyhydramnios? Polyhydramnios is when the amniotic fluid index is more than equal to 25 centimeters or a single largest vertical pocket is more than equal to 8 centimeters. The most common cause of polyhydramnios is neural tube defects. Please do not say that it is swallowing defects. Most common cause is neural tube defects. The other causes of polyhydramnios are, yes, swallowing defects, which includes esophageal atresia, which includes duodenal atresia, then twin pregnancy, because as the number of fetuses are going to increase, there will be more urine production. Then same is the reason in case of diabetes. In diabetes, because fetuses blood sugar levels are high, so if the blood sugar levels of the fetus are high, that will lead to polyuria. So diabetes is another reason for polyhydramnios, and hydrops fetalis, which is seen in Rh negative pregnancy. Right. On the other hand, the important causes of oligohydramnios are the most important cause of oligohydramnios is renal anomalies in the fetus, because the most important overall contributor of amniotic fluid is fetal urine. So the most common reason for oligohydramnios is renal anomalies of the fetus. Apart from this, if mother has got PIH or increased BP, or if there is IUGR, or if it is a case of post-term pregnancy, or if it is a case of premature rupture of membranes, or if mother has taken drugs like indomethacin, then these all can lead to oligohydramnios, right? Okay. Next question. A client tells a nurse in the prenatal clinic that she has vaginal staining but no pain, right? Her history reveals amenorrhea for last 2 months and pregnancy confirmation after a first missed period. So she had a missed period, pregnancy was confirmed, and now after 2 months she is having vaginal staining but there is no pain. Internal os is closed. On per vaginal examination, uterus is 8 weeks in size. So she is 2 months pregnant, 8 weeks uterus, that means they are corresponding. She is admitted to the high-risk unit because she may be having a spontaneous abortion. What type of abortion is suspected? So over here, the most important thing is that the internal os is closed. Now, whenever internal os is closed, there are 3 differential diagnoses which should come to your mind in terms of abortion. Either it could be a case of threatened abortion, or it could be a case of missed abortion, or it could be a case of complete abortion. Threatened abortion means that the process of abortion has begun, no fetal part has come out till now, and the internal os is closed. So just now the abortion can be reversed. So if abortion can still be reversed, it is at a place where it can be reversed, then that's a threatened abortion, right? Complete abortion means the entire process of abortion, including the fetal parts, are all out, and now the internal os is closed. That is what is complete abortion. The entire process of abortion is complete on its own without any interference by the obstetrician. Right? Missed abortion means that the fetus is dead inside the mother's uterus, but the mother is not aware of the fact. So in all these 3 cases, the internal os will be closed. In threatened abortion, internal os is closed. In complete abortion, the internal os is closed. And in missed abortion, internal os is closed. Number 1 indication which tells me which out of these 3 is the diagnosis is the history of the patient. In case of threatened abortion, patient is going to say that just a few drops of blood came out. There may be pain, there may not be any pain, right? So there will be spotting plus minus pain. In case of complete abortion, patient is going to say that I had bleeding, I had pain, and entire product of conception came out, right? And now after that, my bleeding has stopped. Right? So initially there was bleeding, entire product of conception came out, pain was there, but now the bleeding has stopped. Whereas in missed abortion, patient doesn't even know that the fetus inside her is dead. That is because she did not have any bleeding. She will come to you with complaint of dirty brown discharge, vaginal discharge. Now, as I told you, in all these 3 conditions, internal os will be closed. Now, next thing what you have to see is on per abdominal examination. How is the height of the uterus in compared to the period of gestation? In case of threatened abortion, because the entire fetus is still inside the uterus, right? So height of the uterus will be equal to the period of gestation. Like in this case, the internal os is closed. Patient is giving you history of staining. There is no pain. And they are saying that the height of the uterus is comparable to 8 weeks, whereas patient is 2 months pregnant. So that means height of the uterus is equal to the period of gestation. That means it is a case of threatened abortion. Whereas in case of complete abortion, what is going to happen? In case of complete abortion, because the entire fetus is out, the height of the uterus will be less than the period of gestation. Same is the case with missed abortion. In missed abortion also, the height of the uterus is less than the period of gestation. So that rules out missed abortion, that rules out complete abortion. Right? So this particular case is a case of threatened abortion. Right? The next thing which can help you in making a diagnosis is the ultrasound findings. In case of threatened abortion, the fetus will be alive, cardiac activity will be present. In case of complete abortion, the uterus will be empty. Whereas in case of missed abortion, you will get a dead macerated fetus, right? Now, this is when the internal os is closed. Now, suppose the question says internal os is open. Now, if internal os is open, there can be two differential diagnoses. Either it can be a case of inevitable abortion or it can be a case of incomplete abortion. Inevitable abortion means the process of abortion has started, the product of conception have not come out, but the internal os is open. So now the process cannot be reversed. In threatened abortion, parts did not come out, but because the internal os was closed, so the process was reversible. In inevitable abortion, the internal os is open, so now the process of abortion cannot be reversed. Whereas incomplete abortion means the process of abortion has started and the fetal parts have started coming out, right? That's the difference between inevitable and incomplete abortion. Now, in both these conditions, internal os will be open, and in both these conditions, again, based on history, we can tell which type of abortion it is. In case of inevitable abortion, patient will complain of bleeding and pain, but there won't be any history of product of conception coming out. Whereas in case of incomplete abortion, there will be bleeding, pain, and patient will specifically give you a history of product of conception coming out, right? Then when you will do a per abdominal examination, because in case of inevitable abortion, no fetal part has come out, that is why the height of the uterus will be equal to the period of gestation. Whereas in case of incomplete abortion, because fetal parts have started coming out, so height of the uterus will be less than the period of abortion, than the period of gestation. Similarly, when you look at the internal os, in case of incomplete abortion, you can see the product of conception coming out through the internal os. Whereas in inevitable abortion, you will not see any product of conception coming out through the internal os. Clear to all of you, right? So this is how you identify the various types of abortions, and this is very, very important in this question over here, because internal os was closed, so it rules out inevitable abortion and it rules out incomplete abortion. So this particular case is a case of threatened abortion. Clear? Next question, question number 18. A 19-year-old primigravida is 12 weeks pregnant by dates. She has vaginal bleeding and she has an enlarged for dates uterus. So just now when I was telling you the differential diagnosis of height of the uterus more than the period of gestation, I told you in early weeks of pregnancy, one very important diagnosis is molar pregnancy, right? In addition, no fetal heart sounds are heard. Ultrasound shown below is obtained. So this particular ultrasound was seen. Now, what are you seeing in this particular ultrasound? You are seeing over here snowstorm-like appearance. This is a typical ultrasound showing snowstorm-like appearance. So if you are getting an ultrasound like this, if you are getting a patient where there is bleeding in first trimester and their height of the uterus is more than the period of gestation, it means it's a case of molar pregnancy. See, bachcho, there can be three conditions in first trimester bleeding. Either it could be a case of abortion, either it could be a case of ectopic, either it could be a case of molar pregnancy. First trimester bleeding with height of the uterus more than the period of gestation is seen only and only in molar pregnancy and nothing else, right? In case of abortion, the height of the uterus will be equal to or less than the period of gestation. In case of ectopic pregnancy, uterus will not be enlarged, right? Because in ectopic pregnancy, implantation is happening outside the uterus, right? Clear to all of you? The other very important thing is, in case of molar pregnancy, there will be increased beta HCG levels in compared to a normal pregnancy. Whereas in case of ectopic pregnancy and in case of abortion, beta HCG levels will be less as compared to a normal pregnancy. Third very important thing is, whenever they say in a question that there is first trimester bleeding and patient has got excessive vomiting, that is hyperemesis gravitarum, or patient has got symptoms of thyroid storm, or there is PIH, or there is theca lutein cyst. All these are terms which are associated with molar pregnancy, right? Now, in case of molar pregnancy, all of you know that they can be a case of partial mole or it can be a case of complete mole. Partial mole, the karyotype is 69XXY. Partial moles are triploid, whereas complete moles are diploid, 46XX. In partial mole, the extra chromosomes are obtained from the father, whereas in case of complete mole, the entire chromosomes are paternal in origin because there is an empty ova which is fertilized by a sperm and then the entire chromosome number duplicates, right? Now, in case of molar pregnancy, whether it is a partial mole or whether it is a complete mole, in both of them, you are going to see the most common symptom will be first trimester bleeding. Right, first trimester bleeding will be the most common symptom which will be seen here. Please remember, in ectopic pregnancy, the most common symptom is not bleeding. In ectopic pregnancy, the most consistent symptom or the most specific symptom is abdominal pain. In case of molar pregnancy, the most common one is bleeding. Right? Then when you are going to do examination, per abdominal examination, the height of the uterus will be more than the period of gestation, and this is more commonly seen in a complete mole. In case of partial mole, the height of the uterus may be equal, it may be less, or it may be more than the period of gestation. All the complications which I was talking about, PIH, I was talking about thyroid storm, I was talking about hyperemesis gravidarum, I was talking about theca luteal cyst. All these are more commonly seen in complete mole in comparison to a partial mole. Investigation of choice in molar pregnancy is ultrasound, and on ultrasound you get a snowstorm-like appearance, which is typical again of complete mole, right? And in case of molar pregnancy, I was telling you the beta HCG levels are high. In case of a complete mole, the levels are more than equal to 10 to the power of 5 milli-international units, whereas in case of partial mole, they are high, but they are not this much high. And the last point which you have to remember is whether it is a case of partial mole or whether it is a case of complete mole, both of them have got chances of turning into malignancy, and those malignancies are called as gestational trophoblastic neoplasia, in which again more common chances of turning into malignancy are though that by complete mole. Partial mole has got less chance of turning malignant. A very important question which they can ask you is, which is the most common gestational trophoblastic neoplasia once a partial mole turns malignant or a complete mole turns malignant? Please do not answer this question as choriocarcinoma. The most common gestational trophoblastic neoplasia after any kind of molar pregnancy is invasive mole. It is not choriocarcinoma, right? So now look at this question. The most common chromosomal makeup of partial mole or incomplete mole is 46XX and of paternal origin. That is wrong. This is the chromosomal makeup of a complete mole. In a partial mole, it is 69XXY. Older maternal age is not a risk factor for hydatiform mole. Please remember the risk factors for hydatiform mole are old maternal age, vitamin A deficiency. It is more common in developing countries like Philippines, and it is more common with AB blood group. Right? Partial or incomplete H mole has a higher risk of developing into choriocarcinoma. Again, that's wrong. Vaginal bleeding is a common symptom of hydatiform mole. Yes, vaginal bleeding is a common symptom. Hysterectomy is contraindicated as primary therapy for molar women who have completed childbearing. No. So the treatment of molar pregnancy is suction evacuation. But if a female is more than 40 years and if she has completed her childbearing, then you can go ahead with hysterectomy. But whether you do a hysterectomy or whether you do suction evacuation, you have to follow up these patients by their beta HCG levels. Clear? Coming to question number 19, a 25-year-old primary gravida at 28 weeks of pregnancy has BP 160 by 110. Her 24 hours urine albumin is 220 milligrams, right? She has family history of hypertension in mother. Her previous record shows BP normal at 12 weeks and normal investigations. She has developed headache, blurring of vision since day one. What is your diagnosis? Now, because BP is more than 140 by 90, so I know that her BP is high. Now, whenever BP is high in pregnancy, it could be due to two reasons. It could be that a hypertensive female has conceived, and if a hypertensive female conceives, that is what is called as chronic hypertension in pregnancy, or it could be pregnancy-induced hypertension. A very important difference between them is that in chronic hypertension in pregnancy, the increase in BP will be seen before 20 weeks of pregnancy also, whereas in pregnancy-induced hypertension, the increase in BP will be seen only after 20 weeks of pregnancy. Now, in this case, patient is 28 weeks pregnant and her BP at 12 weeks was normal. That means she is not a case of chronic hypertension, right? That's obvious. And since she is not a case of chronic hypertension, she cannot be chronic hypertension with superimposed preeclampsia. Clear? Now, that definitely means she's a case of pregnancy-induced hypertension. Now, in pregnancy-induced hypertension, there can be two varieties. Either it could be a case of preeclampsia or it could be a case of gestational hypertension. In both of them, the increase in BP will be seen after 20 weeks of pregnancy, and in both of them, BP will come back to normal within 12 weeks of delivery. The difference is, in case of preeclampsia, there are two things. Either of these two should be present to say that she's a case of preeclampsia. Number one, proteinuria. How do you define proteinuria? Proteinuria is protein excretion in urine more than equal to 300 milligrams in 24 hours. Now, this patient is having protein excretion 220. So, she is not having proteinuria. The other thing is there should be signs of end organ damage. So, either patient should be having proteinuria or signs of end organ damage. Then we say she's a case of preeclampsia. What are signs of end organ damage? Signs of end organ damage are serum creatinine more than 1.1, increased liver enzymes to more than 2 times their normal value, platelet count less than 1 lakh. Symptoms of headache and blurring of vision, which are the symptoms of headache and visual symptoms, which are the symptoms of cerebral edema and pulmonary edema. Any of these, if they are present, we say that these are signs of end organ damage, and signs of end organ damage means your patient is having preeclampsia. So in this case, although her protein levels are 220, which are less than 300, but she is having headache and she is having blurring of vision. Now, because she is having headache and blurring of vision, that means she is having signs of end organ damage. And whenever signs of end organ damage are present, you call it as preeclampsia. So 100% she's a case of preeclampsia. She's not a case of gestational hypertension, right? Now, preeclampsia is further divided into mild preeclampsia and severe preeclampsia. In mild preeclampsia, BP is more than 140 by 90 but less than 160 by 110. In case of severe preeclampsia, BP is more than 160 by more than equal to 160 by 110. The other difference is in mild preeclampsia, signs and symptoms of end organ damage are not seen, whereas in severe preeclampsia, signs of end organ damage are present. So over here, patient's BP is 160 by 110 and signs of end organ damage are present. That means she's a case of severe preeclampsia, right? The only one thing which I want you to know is what is chronic hypertension with superimposed preeclampsia. Chronic hypertension means that the patient's BP was raised even before 20 weeks of pregnancy. So she is a hypertensive female who has conceived, and suddenly at 20 weeks, either her BP becomes uncontrollable, or suddenly at 20 weeks she starts showing proteinuria, or suddenly at 20 weeks she starts showing signs of end organ damage. Then that is what is called as chronic hypertension with superimposed preeclampsia. Are you understanding, all of you? This is very, very important. The terminology in PIH. PIH in itself is a very, very important topic, right? So you have to know what is eclampsia. You have to know what is HELLP syndrome. You have to know when you have to terminate pregnancy in mild preeclampsia, in severe preeclampsia, in eclampsia, and in HELLP syndrome, right? Then question number 20. A 34-year-old G2P1 at 31 weeks of gestation presents to labor and delivery with complaint of vaginal bleeding earlier in the day that resolved on its own. She denies of any leakage of fluid or uterine contractions. She reports good fetal movements. In her last pregnancy, she had a low transverse cesarean section due to breech. She denies any medical problems. Her vital signs are normal. Her EEG reveals a reactive fetal heart rate. Which of the following is the next step in management? Now, before we decide the next step in management, this is a patient who has come to you at 31 weeks of pregnancy and she is saying that earlier in the day she was having vaginal bleeding. Now, whenever a patient is coming to you at more than equal to 28 weeks with vaginal bleeding, that means it's a case of antepartum hemorrhage. Right? And in antepartum hemorrhage, 3 conditions are included. Number 1, placenta previa. Number 2, abruptio. Number 3, vasa previa. Right? The other thing could be that maybe this patient is having preterm labor. Right? And in labor also, you know that show is present. So show could also be one of the differential diagnoses. So whenever you have a patient who's more than equal to 28 weeks and your question is saying that bleeding is present, you have to keep 4 differential diagnoses in mind. Number 1, you have to keep placenta previa in mind. Number 2, you have to keep abruptio in mind. Number 3, you have to keep vasa previa in mind. And number 4, you have to keep normal labor's show in mind. Right? So how are you going to differentiate between them? See, in case of placenta previa, bleeding will be causeless. That means there won't be any reason for the bleeding. So there won't be any trauma. There won't be anything. Patient will simply say that she just had bleeding. She doesn't know the reason why. Another very important thing in placenta previa is the bleeding is bright red in color and it is painless. It is never associated with any pain. Next thing is there may be initially it could be that the bleeding is less and later on the bleeding could be heavy. So there is a warning hemorrhage. In case of placenta previa, you may get history like this that I had bleeding, then the bleeding stopped, then again I had bleeding and then again the bleeding stopped. This type of history is present in placenta previa. Right? So bleeding is causeless, bleeding is painless and bleeding is recurrent. So there will be episodes of bleeding, then no bleeding, then no bleeding. Right? In this case, fetal heart sounds are normal and when you will do a per abdominal examination, uterus will be relaxed, fetal heart sounds will be easily heard, fetal parts will be easily palpable and height of the uterus will be equal to the period of gestation. Now, whenever there is a case of placenta previa, please remember per speculum and per vaginal examinations are contraindicated. You are never going to put a speculum, you are never going to put your finger inside it because that can lead to excessive bleeding. The only thing which you have to do in placenta previa is you have to get an ultrasound done. Right? Now let's talk about abruptio. In case of abruptio, in contrast to placenta previa, there will be a reason for the bleeding. Either the reason could be any trauma, it could be any accident, or it could be high BP could also be a reason. Right? In case of abruptio, patient will say that there is a dark red color bleeding and there is pain in abdomen which is present. But please remember in abruptio, you will never get a history like this that there was bleeding, then it stopped. There was bleeding, then it stopped. No. Why? Because once the abruptio begins, what is abruptio? That means the placenta has started separating. So once the placental separation begins, it will ultimately end in delivery. So never are you going to get a history that patient had bleeding one day, then it stopped, then she had bleeding one day, then it stopped. These are not the cases of abruptio, right? Another very important thing is an abruptio is that in abruptio there is a variety which is called as concealed variety, where the blood is collecting inside the uterus. So in this case, whenever you are going to do a per abdominal examination, uterus will be very tensed. It will be tender, and because uterus will be tense and tender, you will not be able to listen to fetal heart sounds, fetal parts will not be palpable, and because blood is collecting inside the uterus, height of the uterus will be more than the period of gestation. Right? Now, what happens in vasa previa? In vasa previa, the cord is attached to the membranes. The cord, umbilical cord of the baby is attached to the membranes. So, the moment you rupture the membranes, it is not only the membranes which get ruptured, it is the cord also which gets ruptured. And cord has got umbilical artery, umbilical vein. So, umbilical artery and umbilical vein get ruptured and it is the fetal blood which starts coming out from mother's vagina. This is what is vasa previa. So, in case of vasa previa, again you have painless bleeding. Right? So, if there is no pain in abdomen and there is bleeding, either it could be a case of placenta previa or it could be a case of vasa previa. How are you going to know from the question? In vasa previa, always and always two things will be present. Number one, there will be history of rupture of membranes. Right? So, the question is going to say that the membranes were ruptured and then bleeding happened. Number one. Number two, in case of vasa previa, because the bleeding is coming out is fetal in origin. So in case of vasa previa, the amount of bleeding and the fetal distress will be out of proportion. Bleeding will be very less, but it will lead to fetal distress. In case of placenta previa, fetal distress is not present, whereas in vasa previa, fetal distress is present. In case of placenta previa, you will not get such history that the membranes were ruptured and then bleeding happened. In case of vasa previa, you are going to get such history. Is that clear to all of you? So that is how you differentiate placenta previa and vasa previa. The last thing more differential diagnosis which you have to remember is it could be that the patient has gone into preterm labor. Now, if the patient has gone into preterm labor, definitely there will be history of uterine contractions. So patient will feel the contractions and in question it will be given to you. So over here, uterine contraction will be present. Right? And because there will be uterine contraction, definitely it will be painful. Right? So, pain and bleeding. Now, again, you have two options. Either it could be abruptio, either it could be normal labor, the show. Right? How are you going to differentiate? Because in abruptio also there is pain and in normal labor also there is pain. How am I going to differentiate? I am going to differentiate on the basis of fetal heart sounds. In normal labor, will there be fetal distress? No. Whereas in abruptio, I'm going to get a history of fetal distress. Right? Another thing is, in case of labor, whenever they have to tell you about labor, two very important things will be present. Definitely the question is going to tell you that the patient is dilating. So pain associated with dilatation of the cervix, that is something which is characteristic of labor. Right? So pain along with dilatation of labor, along with blood mixed mucus discharge, that is what tells you that the question is talking about show. Right? Now, in this question over here, what am I getting? In this question, I am getting that patient came to me at 31 weeks. She had bleeding in the day and now the bleeding has stopped. Bleeding is painless. There are no uterine contractions, right? And fetal heart sounds are absolutely normal. So definitely this is a case of placenta previa. Now they are not asking you the diagnosis. They are asking you what is the next step. So send her home since her bleeding has completely resolved and she has good fetal movements. Now, whenever there is a case of placenta previa, you have to know which kind of placenta previa it is, right? So, I am not going to send her home, even if I think about conservative management, because in case of placenta previa, their bleeding is recurrent, right? If I send her home, maybe she starts bleeding again, right? So, I am not going to send her home. Next is perform sterile per speculum examination. No. Perform PV examination. No. Do an ultrasound examination. Yes, I'm going to do an ultrasound examination and I'm going to manage her conservatively or expectantly, and the expectant management of placenta previa is called as the McCafe and Johnson regime. Right? So I am going to do a McCafe and a Johnson regime. Clear to all of you? Okay, so now coming to question number 21. In question number 21, you have a 32-year-old chronic hypertensive female who's undergone forceps delivery, right? And you noted that there is brisk vaginal bleeding. Oxytocin was given 200 milli international units per minute. When you notice that the fundus is firm, but the lower uterine segment is boggy, which of the following is the next step in management of the patient? So this patient is having bleeding after forceps delivery, and all of you know that if a patient has hypertension or if she's undergone instrumental delivery, these are risk factors for PPH. So this patient is having PPH, and for PPH, oxytocin was given to her. Now they have asked you what is the next step in the management, right? Now please, bachcho, one thing is very important for you to know, that in PPH, you have to follow an algorithm, and that algorithm is very, very important. The steps have to be followed in the same manner how I'm going to tell you now. So whenever a patient comes to you for PPH, there are certain non-specific measures which you have to do. Like, for example, you have to call for help, you have to put 2 large IV cannulas, you have to catheterize the patient, and there are certain specific measures which you have to do. For example, you have to do a uterine massage. Uterine massage is a part of management of PPH, and you have to give injection Tranexa, and you have to start immediately with medical management. In medical management, the first line drug which you have to give is oxytocin. The dose of oxytocin which you have to give in PPH is 20 international units, right? And this 20 international units, it has to be dissolved in either normal saline, or it has to be dissolved in ringer lactate. It can be given as IV infusion, or it can be given intramuscularly. You should never give oxytocin as IV bolus because it can lead to cardiac arrest. Right now, this is the dose which you are using when you are treating PPH. But suppose if they ask you what is the dose of oxytocin which is used in active management of third stage of labor, active management of third stage of labor is the best method to prevent PPH. So they can ask you the same question as active management of third stage of labor, or they can ask you that for preventing PPH, what is the dose of oxytocin? Then in that case, it is 10 international units. Now, suppose bleeding is uncontrolled by oxytocin, then you have to go to the next drugs. Now, in case of PPH, after oxytocin, the next drug which I am going to choose will be carboprost, that is PGF2 alpha. Right? And this is also called as Hembate, or it is also called as dinoproston. The dose which you have to give is 0.25 mg intramuscularly. This you can repeat in every 15 to 30 minutes, and maximum which you have to give is 8 doses. Now, this is the dose which is given to treat PPH. Right? Now, in case of PPH, the gold standard drug is this carboprost, right? First line drug is oxytocin. Now, apart from this, you may use methergin and you may use misoprostol. Methergin and misoprost are add-on drugs, right? So in these add-on drugs, you have methergin and misoprost. The dose of misoprost to treat PPH is 800 micrograms, which should be given sublingually. Now, this is the dose which is recommended, route and dose which is recommended by WHO. But otherwise, when we see that in clinical practice, misoprost is also used to treat PPH by giving it per rectally. And when you are giving it per rectally, the dose which you are going to give is 800 to 1000 micrograms. Please remember that misoprost is available in tablet form, and you can give it orally, you can give it sublingually, you can give it per rectally. But in a patient of PPH, you cannot give it per vaginally because patient is bleeding profusely. And obviously, misoprost is in the form of a tablet, so you cannot give it as IV drug. Right? So these are two routes which are not used while you are treating PPH. Clear to all of you? Now, when it comes to prevent PPH, that is an active management of third stage of labor, suppose oxytocin is not available, although oxytocin is first line drug, then in that case, you can give methergin and you can give misoprost also. Misoprost is PGI. Now, for preventing PPH, the dose of misoprost is 600 micrograms orally. This is what is recommended by WHO. For treating PPH, it was 800 micrograms sublingually. For preventing PPH, it is 600 micrograms orally. Apart from that, you can give synthetic oxytocin. Synthetic oxytocin is carbetocin. This carbetocin, the dose of carbetocin has been asked in your exams, and it is 100 micrograms. What you tend to do is you tend to confuse carbetocin with carboprost. Carboprost is PGF2 alpha and its dose is 0.25 mg, right? 250 micrograms. Right, in micrograms if you want to remember. But in case of carbetocin is synthetic oxytocin whose dose is 100 micrograms and it has to be given slow IV over 1 minute. Right. Then, as I told you, you can also use misoprost, and the dose of misoprost is 600 micrograms orally in case of preventing PPH. Right? Now, when you are treating PPH, if the bleeding is not controlled by giving medical management, and this medical management you are going to try for 30 minutes. If in 30 minutes the bleeding is not controlled, then you are going to go for mechanical methods. In mechanical methods, there are two methods, and that is, one is bimanual compression of the uterus. So your one hand will be inside the uterus, one hand behind the uterus parabdominally, and you're going to compress the uterus between both your hands. The other method is you can use a balloon catheter, which is called as a Bakri balloon catheter or a Foley's catheter, and you can fill it with normal saline, and maximum you can fill it up till 500 ml. And once you take the bulb inside, you fill it with warm normal saline, and because it will inflate, it is going to put pressure on the uterus and the bleeding will stop. Now, suppose if mechanical methods also fail, then you go to surgical methods, and surgical method, if the family is complete, is hysterectomy. Surgical method, if the family is not complete, is number one, you can use sutures like B-link sutures. In B-link sutures, what you are doing? In B-link sutures, you are giving sutures like this antero-posteriorly on the entire length of the uterus and tightening it, number one. Or you can go for devascularization procedures, like you can go for ligation of uterine artery, ligation of ovarian artery, or ligation of the anterior division of internal iliac artery, right? But still, if bleeding continues, so even if the family is not complete, then ultimately we have to go for hysterectomy. So that is the protocol which you have to follow in management of PPH, and many questions are asked on management of PPH, right? So this protocol or this algorithm is very, very important for all of you. Now, in this question which was asked, the question was that oxytocin is given to her and still her lower part of the uterus is boggy, right? So still a patient is continuously bleeding. Now, what is the next step? So is the next step giving methergin, or you are going to give 20 units of oxytocin bolus? You are never going to give oxytocin bolus. Or you are going to give misoprost or hembate. I told you that methergin and misoprost, they are add-on drugs. The gold standard drug will be, you have to give hembate 250 micrograms intramuscularly. 0.25 mg is equal to 250 micrograms, right? And this you have to give intramuscularly. Clear to all of you? Next question. All of the following are indications of delayed cord clamping except option A, HIV positive mother, option B, COVID positive mother, option C, Rh negative mother with indirect Coombs test negative, option D, Rh negative mother with indirect Coombs test positive. So they are asking you, all of the following are indications of delayed cord clamping except. So I was talking to you that the best method to prevent PPH is active management of third stage of labor. And what are the steps which are there in active management of third stage of labor? Very, very important question. Number one is you have to give a uterotonic after the delivery of the baby, and the first line of drug, the first line uterotonic is oxytocin, and that is the most important step, right? Second step is delayed cord clamping. Third step is delivery of the placenta by controlled cord traction, and the fourth step is intermittent assessment of uterine tone. Please remember that earlier the fourth step was uterine massage, but now it is not uterine massage. Now it is intermittent assessment of uterine tone. After how many minutes are you going to assess the uterine tone? You are going to assess the uterine tone after every 15 minutes. Now, in active management of third stage of labor, delayed cord clamping is included, which means you have to clamp the cord within 1 to 3 minutes of the delivery of the baby. Early cord clamping is not a part of active management of third stage of labor, yet there are certain conditions in which you will have to do early cord clamping. And what are those conditions? Number one, in Rh negative pregnancy. Now, Rh negative pregnancy it could be that Rh negative pregnancy mother is already sensitized, already feto-maternal hemorrhage has occurred. Now, if already feto-maternal hemorrhage has occurred, in that case, I don't need to do early cord clamping. I have to do early cord clamping only if feto-maternal hemorrhage has not yet occurred, right? And how do I come to know whether feto-maternal hemorrhage has occurred or not? I come to know feto-maternal hemorrhage has occurred or not by doing indirect Coombs test. Indirect Coombs test has to be done on mother's blood, right? And direct Coombs test has to be done on baby's blood. Now, if indirect Coombs test is negative, that means feto-maternal hemorrhage has not occurred, and that means you are going to go for early cord clamping. If in case indirect Coombs test is positive, then that means you are not going to go for early cord clamping. In that case, you will go for delayed cord clamping. Now, you're going to ask me why. The reason is, see, early cord clamping is done to prevent feto-maternal hemorrhage. Now, if already feto-maternal hemorrhage has occurred, then why am I going to go for early cord clamping? Then it is better that I go for delayed cord clamping, and that extra small amount of blood which is present in the baby's cord, let it go to the fetus, right? So always we study that Rh negative pregnancy, we do early cord clamping, but in which category of Rh negative patients? In those category in whom feto-maternal hemorrhage has not occurred, that means indirect Coombs test is negative. The only other indication for doing early cord clamping is if baby is a known case of heart disease. In these two conditions, I'm going to go for early cord clamping. In rest, all of the other conditions, I go for delayed cord clamping. Whether it is HIV positive female, I'm going to do a delayed cord clamping. COVID positive mother, I'm going to go for a delayed cord clamping. Preterm labor, I'm going to go for a delayed cord clamping. Even if it is an RH negative mother whose indirect home test is positive, I'm going to go for a delayed cord clamping. Only in case of RH negative with indirect home test negative, I'm going to go for an early cord clamping. So the answer is option C. Clear to all of you? Right? Now, many times they ask questions on active management of third stage of labor, and they give you a question that all of the following are included in active management of third stage of labor except. Now, in that except, you have to always look for early cord clamping. That is the best answer, because early cord clamping is not included in case of active management of third stage of labor. But just in case early cord clamping is not given, then in that case you will have to look for uterine massage as the answer, right? Because uterine massage was earlier a part of active management of third stage of labor. Now it is not a part of active management of third stage of labor, right? Now, in case of uterotonics, please remember, read your options very carefully. If they say all of the following are part of active management of third stage of labor except, and in the options it is given oxytocin IV bolus. So, is oxytocin IV bolus given as a part of AMTSL? Oxytocin is never given as IV bolus, right? Because it will lead to bradycardia and hypotension. Clear to all of you? Right. Similarly, methergin is also never given IV. Why is methergin not given IV? Because it leads to hypertension. Apart from this, please remember, bachcho, that in case of methergin, they can also ask you what are the contraindications for giving methergin. So, methergin is contraindicated in case of preeclampsia, in case of eclampsia, because in both these cases, already the BP is very high. And whenever you give methergin, methergin increases the BP, right? Then it is contraindicated in case of a female with heart disease. In heart disease females, methergin is or methyl ergometrin is contraindicated. It is also contraindicated in females with peripheral vascular disease, and it is contraindicated if first twin is after the delivery of first twin. Right? So these are the conditions, and in RH negative females. So these are all the conditions in which injection methyl ergometrin is contraindicated, and again they should be on your tips. Next question. A 20-year-old G1 at 41 weeks is in labor. The fetal head is at introitus and beginning to crown. Obstetrician feels it is not necessary to cut an episiotomy. So first tell me, does WHO say that episiotomy should be given to all females who are delivering? No. WHO says that episiotomy should not be given to all females who are delivering. It should be given only if it is indicated, right? So obstetrician here feels that it is not indicated, and that's fine. A perineal tear occurs, right? So if WHO says that episiotomy is not indicated in all pregnant females who are delivering, then what is the best method which is advised by WHO to prevent perineal tear? So the best method which is advised by WHO to prevent perineal tear is not episiotomy. It is that when the head of the baby is delivering, the obstetrician should support the perineum with one hand, and they should have a controlled delivery of the head of the fetus. So with one hand, I have to do a controlled delivery of the head of the fetus, and with the second hand, I have to support the perineum. This is what is called as modified Ritgen maneuver. Modified Ritgen maneuver. Right? So this is the best method of preventing perineal tear as advised by WHO. Right? Now, this obstetrician in the question is saying that she did not feel the need of episiotomy, but unfortunately, perineal tear happened. And it extends through the sphincter of the rectum, but the rectal mucosa is intact. How should you classify this type of tear? So, how are you going to classify this type of tear? So, if rectal mucosa is intact, but the sphincter is torn, that means it is a third degree perineal tear. Right? So let's quickly revise the degrees of perineal tears. First degree perineal tear is when the vaginal mucosa is torn. Second degree means vaginal mucosa is torn, and along with that, the muscles are also torn. Third degree means that now the anal sphincters are torn. right? Apart from vaginal mucosa and muscles. And in this, we have A, B, and C. A means less than 50% of external anal sphincter tone. B means more than equal to 50% of external anal sphincter tone. And C means external and internal anal sphincter tone, right? And fourth degree perineal tear means that the tear is extending to the rectal mucosa. So if a tear extends to the rectal mucosa, that means it is a 4th degree perineal tear. Now, suppose you notice a tear within 24 hours of delivery, then the time of repair of a perineal tear is immediate. But if a perineal tear is noted after 24 hours of delivery, then you have to wait for 2 weeks before you repair the perineal tear. Clear to all of you? Okay. Then comes next question. A 32-year-old G1 at 39 weeks gestation is admitted in labor room and at 4 centimeters dilatation and is completely effaced. Fetal head is at 0 station. You performed clinical pelvimetry and find the following. Diagonal conjugate is 10 centimeter. Interischial spine distance is 11 centimeters with non-convergent side walls, and intertuberous distance is 9 centimeters. Those measurements describe which of the following types of pelvis? Option A, normal pelvis. Option B, contracted pelvic inlet. Option C, contracted mid-pelvis. Option D, contracted pelvic outlet. And option E, generally contracted pelvis. So you have to tell me whether these findings are of a normal pelvis or they are of a contracted pelvis. And if it is contracted at the level of inlet or at the level of mid-cavity or at the level of outlet. Now, before we proceed with the contracted pelvis, just one thing which I want to tell you is, over here, patient is 4 centimeters dilated. See, as per WHO and as per partogram, 4 centimeters dilatation means patient is in active phase, right? So whenever your question is talking about WHO or they are talking about partogram, that in a partogram, from what dilatation do the markings begin? So all of you know that in a modified WHO partogram, the partogram begins only at the active phase, and since active phase as per WHO is beginning at 4 centimeters, so the markings are going to begin at 4 centimeters, right? But this is not as per the clinical scenario. As per ACOG and as per all the, practically or clinically what we say is, as per ACOG and as per practical scenario, active phase means when the dilatation is more than equal to 6 centimeters, right? So please do not get confused. For all questions related to partogram and whenever the word WHO comes, you have to say active phase begins at 4 centimeters. But for all practical questions, for all clinical based questions, active phase begins at 6 centimeters dilatation of the cervix. One thing clear to all of you? Okay. Now let's talk about pelvis. Now, in pelvis, we have the pelvic inlet, the mid-pelvis and the outlet. Now, in case of pelvic inlet, if I want to know whether the pelvic inlet is normal or whether it is contracted, I have to look at obstetrical conjugate. If obstetrical conjugate is less than 10 centimeters, that means inlet is contracted. Normally, obstetrical conjugate is between 10 to 10.5 centimeters, right? So, what is obstetrical conjugate? So, suppose this over here is the sacral promontory and this is pubic symphysis. Obstetrical conjugate is the diameter, AP diameter from middle of pubic symphysis up till the sacral promontory. This is obstetrical conjugate. Then true conjugate is the diameter from upper border of pubic symphysis up till sacral promontory, and diagonal conjugate is from lower border of pubic symphysis up till the sacral promontory. Normally, diagonal conjugate is 12 centimeters, OC is 10 to 10.5 centimeters, and true conjugate is 11 centimeters, right? So, whenever I have to talk about contracted inlet, the diameter which I am going to look at is obstetrical conjugate. And how much should obstetrical conjugate be? It should be less than 10 centimeters. Then I'm going to say that the inlet is contracted. Now, please remember that the only diameter which you can clinically measure, the AP diameter of the inlet which can be clinically measured is diagonal conjugate. I cannot measure obstetrical conjugate. Why? Because when I'm going to put my finger is going to touch the lower border of pubic symphysis and sacral promontory, and the diameter from lower border of pubic symphysis up till sacral promontory is diagonal conjugate. So clinically I can measure diagonal conjugate. right? But I am defining the inlet contraction in terms of obstetrical conjugate. So in that case, how do I come to know what is the value of obstetrical conjugate when I cannot measure it? What I have to do is, whatever is the value of diagonal conjugate, from that you have to subtract 2 centimeters to get the value of obstetrical conjugate, right? So normally diagonal conjugate is 12 centimeters, and if you subtract 2 centimeters from it, the obstetrical conjugate comes as 10 centimeters. Clear to all of you till here? Now, in this patient, diagonal conjugate is 10 centimeters. So, if diagonal conjugate is 10 centimeters, what will the obstetrical conjugate be? Obstetrical conjugate will be diagonal minus 2, which is 10 minus 2, which is 8. Right? And just now I am telling you, if obstetrical conjugate is less than 10, then that means it is contracted inlet. Now here obstetrical conjugate is 8 centimeters. That means yes, it is a contracted inlet for sure. But in order to call it as overall contracted, I will also have to see whether mid pelvis is contracted or not and whether outlet is contracted or not, right? Now, mid pelvis is said to be contracted or cavity is said to be contracted if interischial diameter is less than 8 centimeters. Normally, IID or interischial diameter, which is also called as the bispinous diameter, the distance between the two ischial spines. Right? So mid-pelvis lies at the level of ischial spine. So if I am measuring both the ischial spine, the distance between the ischial spines, and if it comes out to be less than 8 centimeters, I say it is a contracted mid-pelvis or a contracted cavity. Clear to all of you? Normally, how much is IID? Normally, interischial diameter or bispinous diameter is 10 centimeters. Right? And when do I say that the outlet is contracted? Outlet lies at the level of ischial tuberosities. So I have to measure the distance between the two ischial tuberosities. Normally the distance between two ischial tuberosities is 11 centimeters. If it is less than 8 centimeters, then I say that the outlet is contracted. Have you understood? Inlet is contracted if obstetrical conjugate is less than 10. Mid-pelvis or cavity is contracted if bispinous diameter or interischial diameter is less than 8. And outlet is contracted when bituberous diameter or intertuberous diameter is less than 8. Right? Now, in this case, the interischial spine diameter is 11, which means it's normal. And intertuberous diameter is 9 centimeters. If it is less than 8, then I say outlet is contracted. So that means outlet is also normal. So in this pelvis, mid-pelvis is normal, outlet is normal. Only contraction is at the level of pelvic inlet. Please remember whether the pelvis is contracted at the level of inlet or at the level of mid-pelvis or at the level of outlet. Management always is cesarean section. You cannot proceed with vaginal delivery no matter which part of the pelvis is contracted. Clear to all of you, right? So, vaginal delivery is not possible whenever there is a contracted pelvis. Vaginal delivery is not possible if there is a Naegeli's pelvis. What is a Naegeli's pelvis? Naegeli's pelvis is a pelvis in which one ala of the sacral bone is absent. Or if it is a case of Robert's pelvis, what is a Robert's pelvis? In which both the ala of the sacral bone are absent. Vaginal delivery is also not possible if lie of the baby is transverse. So if baby is lying in a transverse lie is same as shoulder presentation. So whether it's a transverse lie or whether it is shoulder presentation, again, vaginal delivery is not possible. Vaginal delivery is also not possible in case of bro presentation and in case of face in mento posterior. In case of face presentation, the chin of the baby can be facing anteriorly, then it will be called as mento anterior, or the chin of the baby can face posteriorly, it will be called as mento posterior. In case of chin facing anteriorly, vaginal delivery is possible. In case of chin facing posteriorly, vaginal delivery is not possible. So please make a list of these conditions that in case of transverse lie, vaginal delivery is not possible. In bro, vaginal delivery is not possible. In face, in mento, posterior, vaginal delivery is not possible. Vaginal delivery is not possible in monochorionic, monoamniotic twins. Vaginal delivery is not possible in case of placenta previa. If it is type 3 or type 4, that is your incomplete or complete varieties of placenta previa, then vaginal delivery is not possible. Please remember, in case of infections, if there is an active genital herpes infection in the mother, then you are going to go for cesarean section. In that case, vaginal delivery is contraindicated. But in case of HIV in pregnancy in India, vaginal delivery is not contraindicated. Similarly, in COVID-19 infection, if mother has COVID-19 infection, then again vaginal delivery is not contraindicated, right? So you can go ahead with vaginal delivery in HIV positive mothers, and you can go ahead with vaginal delivery in COVID-19 mothers, COVID-19 positive mothers, right? In case of HIV positive mothers, artificial rupture of membranes during vaginal delivery and placing of fetal scalp electrodes and using instruments is contraindicated. But in COVID-19 patients, if you are taking them up for vaginal delivery, then none of this is contraindicated. You can go for artificial rupture of membranes, you can put fetal scalp electrodes, you can go for instrumental delivery. In both COVID-19 and in HIV positive mothers, delayed cord clamping has to be done, right? So these were in general contraindications of vaginal delivery. Now, next question. A 38-year-old G2P1 at 39 weeks is in labor. She has had one prior vaginal delivery of 3.8 kgs infant. 1 week ago, the estimated fetal weight was 3.2 kgs by ultrasound. Over the past 3 hours, her cervical examination remains changed at 6 centimeters. Fetal heart rate tracing is reactive, and intrauterine pressure catheter reveals 2 contractions in 10 minutes with amplitude 40 millimeters each. Which of this is the best management for the patient? Please see, here patient is 6 centimeters dilated. Now, because patient is 6 centimeters dilated, that means she is in active phase, right? Now, in active phase, the main thing which has to happen is dilatation of the cervix, and the minimum rate of cervical dilatation should be 1 centimeter per hour. Now, if there is a problem in active phase, there can be 2 problems. One is active phase can be slow, which is called as protracted active phase. In protracted active phase, dilatation will be less than 1 centimeter per hour. And the other thing could be arrest of active phase. In active phase arrest, there is no dilatation, right? So suppose in this female, they would have said that initially her dilatation was 6 centimeters, and after 3 hours, her dilatation is 7 centimeters. Then I would have said that she is a case of protracted active phase, right? Because the dilatation is happening slowly. Right? Now, over here, what is the case is that the dilatation is not happening at all. She was 6 centimeters dilated 3 hours before, and just now also she is 6 centimeters dilated, right? So, is this a case of active phase arrest? No, it is not a case of active phase arrest. Why? Because in order to call it as active phase arrest, there are 3 things which should be fulfilled. Number 1, you have to observe the patient for a period of 4 hours. So for at least 4 hours, there shouldn't be any dilatation at all. So for a period of 4 hours, the patient should remain at the same dilatation. That's number 1. Number 2, you are going to call it as a case of active phase arrest only and only if uterine contractions are adequate, right? If uterine contractions are adequate, then only, and in spite of good uterine contractions, for 4 hours patient has not dilated, then you call it as a case of active phase arrest. And the third thing is membranes should be ruptured. Only if all these 3 things are fulfilled, then you say it's a case of active phase arrest. Number 1, you have to observe a patient for a period of 4 hours. Number 2, uterine contractions should be adequate. Then only you say it's a case of active phase arrest. And number 3, membranes should be ruptured. Right? Then you say it's a case of active phase arrest. And if actually there is a case of active phase arrest, then the management is cesarean section. But over here, patient has been observed only for a period of 3 hours. For a period of 3 hours, she has been observed. She is 6 centimeters dilated earlier also and now also. So she's not observed for a period of 4 hours. So it's not active phase arrest. Number 2, are her uterine contractions adequate? So how do you define adequate uterine contractions? Adequate uterine contractions are defined as if there are 3 contractions in 10 minutes. So there have to be 3 contractions in 10 minutes, each contraction lasting for a period of 45 seconds and each contraction raising the intrauterine pressure to 65 to 75 millimeters of mercury. Then you say it is adequate uterine contraction. This female is having 2 contractions in 10 minutes. They are not 3 contractions. Amplitude is 40 millimeters. It should have been 65 to 75. That means her uterine contractions are not adequate. And whenever uterine contractions are not adequate, what is the best way of making them adequate? The best way of making them adequate is by giving oxytocin. So in this case, because uterine contractions are not adequate, I am not going to say that it is a case of active phase arrest. Have you all understood? Right. So all of you know in first stage of labor, there is a latent phase and active phase. So active phase abnormalities, I have told you. Now in latent phase also there can be an abnormality, and that abnormality could be prolonged latent phase. How would you define prolonged latent phase? If the latent phase is more than equal to 20 hours in a multigravida female, in a primigravida female, or more than equal to 14 hours in a multigravida female. And what is the treatment of a prolonged latent phase? The treatment of prolonged latent phase is sedation. Right? So sedation is a method to treat prolonged latent phase, right? Management of protracted active phase. That means active phase is going slow. What is the management? You have to give oxytocin. You have to increase the speed of the labor by giving oxytocin and by doing artificial rupture of membranes. What is the management of arrest of active phase? The management of arrest of active phase is cesarean section. Clear? Okay, now we are going to talk about some important questions in gynae, and when we are going to start with questions in gynae, the first thing which I want you to revise is staging of cancer cervix. That's a very, very important staging. I know you tend to forget it, so please revise staging of cancer cervix. Let's do a question on it. A 51-year-old woman is diagnosed with invasive cervical cancer by cone biopsy. Pelvic examination and rectal examination reveal parametrium to be free of the disease, but the upper part of the vagina is involved with the tumor. IVP and sigmoidoscopy are negative, but CT scan shows that pelvic and para-aortic lymph nodes are grossly enlarged. The patient is classified at which of the following stages, right? So please remember that as per the new FIGO classification of a new FIGO staging of cancer cervix, now CT scan is a method used for staging of cancer cervix. Earlier, CT scan was not used as a method for staging of cancer cervix, and the results of CT scan did not alter the stage. But now CT scan is used as a method for staging cancer cervix. Now over here, what we are seeing is that upper part of vagina is involved. So in which stage is upper part of vagina involved? See, broadly remember that in stage 1, cervix is involved. In stage 2, upper part of vagina is involved. In 2A, the parametrium is not involved. In 2B, parametrium is involved. In stage 3, lower part of vagina is involved. Then you have 3A, 3B and 3C. In 3A, it is the pelvic side wall is not involved. In 3B, the pelvic side wall is involved. Right? And in 3C, pelvic and para-aortic lymph nodes are involved. In stage 4, there is metastasis. Right? This is broadly what I am telling you. Apart from this, you have to remember that in case of stage 3B, when I was saying that the pelvic side wall is involved, along with the pelvic side wall, if there is, ureter involvement is seen or kidney involvement is seen. So if there is hydroureter or hydronephrosis, then you put it in stage 3B. So generally this question would be asked that ureter is involved in which stage? It is involved in stage 3B. right? Upper vagina is involved in stage 2, lower vagina is involved in stage 3, right? Lymph nodes are involved in stage 3C. In stage 4, there is metastasis. 4A means bladder and rectum involved. 4B means distant metastasis, including superficial inguinal lymph nodes, right? So pelvic and para-aortic are involved in 3C, in which 3C1 is pelvic, 3C2 is para-aortic. Whereas superficial inguinal lymph nodes are involved in stage 4B. This is broadly what you have to remember. Now, in this patient, we are seeing that the upper part of vagina is involved, parametrium is not involved. That means it is stage 2A, number 1. Now we are seeing that IVP is negative, sigmoidoscopy is negative, but CT scan is showing that pelvic and para-aortic lymph nodes are involved. Now, with the moment CT scan says pelvic and para-aortic lymph nodes are involved, I know that it is involved in stage 3C, right? So whenever you have to tell a stage, you are going to do all the investigations, and from the investigations, you are going to take out which is the most distant stage, the most serious stage, right? So the later one you have to take, not the former one. So over here, by examination, I have seen that it is stage 2A, but by CT scan, I have come to know that it is stage 3C. So my answer here will be stage 3C. Is that clear to all of you? Right? Then, next question. A 26-year-old woman presents for her first pap smear. She was sexually active with only one partner. Her physical examination is completely normal. However, 2 weeks later, her pap smear results return and they show it as HSIL. Which of the following is the most appropriate next step in the management of this patient? Again, these are very, very important questions that whenever a pap smear is done and you get a report, how do you manage further? The first thumb rule which you have to remember is that whenever you get a report from pap smear, you always have to confirm it first, because pap smear is a screening test. It is not a diagnostic test. So based on the result of pap smear, I am never going to treat the patient, right? So I am never going to perform LEEP. Right? In case of CIN, the management is LEEP. In case of CIN2 and CIN3, hysterectomy is not done. But then, I am not going to do LEEP also, that is loop electroexcisional procedure, unless and until I confirm the findings of pap smear. Right? And how am I going to confirm the findings of pap smear? That depends upon what report has come. So if report comes as HSIL, which is high squamous intraepithelial lesion, or if report comes as ASC-USH. ASC-USH means atypical squamous cells of unknown significance, where H cannot be ruled out, where high squamous intraepithelial lesions cannot be ruled out. So whenever the pap smear report shows words of H, the word H is there. Always and always, irrespective of the age of the patient, the next step is colposcopy. So whenever pap smear report has the word H, that means there are high chances of malignancy. H means high chances of malignancy. You have to go for colposcopy. Right? Irrespective of the age of the patient. Clear? Now suppose report comes as LSIL or report comes as atypical squamous cells of unknown significance without this letter H. In that case, if patient is less than 25 years, so whether it is a case of LSIL or whether it is a case of ASC-US, if patient is less than 25 years, you are going to repeat pap smear after a period of 6 months to 1 year. Right? But if patient is more than equal to 25 years, in that case, if report is LSIL, you are going to do a colposcopy. If your report is ASC-US, you are going to do HPV DNA testing. HPV DNA testing, which is done after the report of pap smear, is called as reflex HPV DNA testing. Right? So irrespective of age, if report comes as HSIL or ASCH, then the answer is colposcopy immediately. If the report comes as LSIL or ASC-US without the letter H, then look at what is the age of the patient. If age of the patient is less than 25 years, in both these cases, you have to go for pap smear. So you're going to say, I'm going to repeat a pap smear. But if patient's age is more than 25 years, then in LSIL, I'm going to go for colposcopy. In ASCUS, I'm going to go for HPV DNA testing. Clear? So over here, report has come as HSIL. Irrespective of the age of the patient, I have to perform colposcopy. Clear to all of you? Right? Okay, next question. A 57-year-old menopausal female presents to your office for evaluation of postmenopausal bleeding. She is morbidly obese, hypertensive and diabetes. An endometrial sampling was done and it shows complex endometrial hyperplasia with atypia. Which of the following is the best treatment? Now first tell me, whenever you are getting a patient who is obese, who has hypertension and diabetes, this is a triad which is called as corpus cancer syndrome. And that indicates she has increased chances of endometrial cancer. Now, as it is, patient is coming to you with postmenopausal bleeding, and so what we thought was we are going to do endometrial biopsy. Rightly, endometrial biopsy was done. And when endometrial biopsy was done, we saw that the patient has endometrial hyperplasia, complex endometrial hyperplasia with atypia. Please remember, a patient of endometrial hyperplasia is going to come to you with complaint of excessive bleeding. It could be excessive bleeding in the perimenopausal age group, or it could be excessive bleeding or postmenopausal bleeding after patient has attained menopause, right? And in this case, whenever patient comes to you with excessive bleeding, the investigation of choice becomes your endometrial biopsy. Right? So in perimenopausal age group also the investigation of choice is endometrial biopsy. In postmenopausal bleeding also the investigation of choice is endometrial biopsy, because we are suspecting that this excessive bleeding is either due to endometrial hyperplasia or we are suspecting it is due to endometrial cancer. Right? Now, whenever we are going to do endometrial biopsy, the report will tell us whether we are dealing with hyperplasia or whether we are dealing with endometrial cancer. One very important question is, what percentage of patients who have postmenopausal bleeding, they actually have endometrial cancer? 10% females. Then what is the most common cause of postmenopausal bleeding? The most common cause of postmenopausal bleeding is atrophic endometrium. Right? Or senile endometritis. Okay, so that's a different story altogether. Now, in this case, when the report came as complex hyperplasia with atypia. So, whenever you get the report as hyperplasia with atypia or hyperplasia without atypia, there are two different categories. Hyperplasia without atypia, whether it is simple or whether it is complex, it has very less chances of malignancy. In simple hyperplasia without atypia, the chances are 1%, and in complex, the chances are 3%. Now, because there is endometrial hyperplasia, that means there is excessive estrogen, and in order to control that excessive estrogen, the hormone which I am going to give to the patient is progesterone. So, the drug of choice is progesterone if the report comes as without atypia. But on the other hand, if the report comes as with atypia, whether it is simple or whether it is complex, the chances are 8% and 30% of malignancy, which are very, very high chances. So in this case, definitely the best management is I have to do a total abdominal hysterectomy, and depending upon the age of the patient, I may or I may not remove the ovaries. Right? But before I proceed to total abdominal hysterectomy, one very important thing which I have to remember is that because these patients have high chances of malignancy, I have to rule out malignancy first. I have to see that maybe I have to do a more complicated hysterectomy rather than total abdominal hysterectomy, and for that I will have to go for the gold standard investigation for diagnosing endometrial cancer, and that is fractional curettage and hysteroscopy. So whenever the report comes as atypical endometrial hyperplasia, whether it is simple or whether it is complex, read the question very carefully. If they ask you what is the next step, next step is I have to do fractional curettage and hysteroscopy. If they ask you what is the best step, best management is I have to do hysterectomy, total abdominal hysterectomy. Clear to all of you? Now, in this case, there is complex endometrial hyperplasia with atypia, and they are asking me the best treatment. They are not asking me the next step. So, in this case, my answer will be total abdominal hysterectomy. Right? Since the patient is 57 years, if in the options oophorectomy was mentioned, I would have chosen that answer. Right? Beyond 45 years of age, I go for bilateral salpingo oophorectomy. Less than 45 years of age, I will not do oophorectomy. Otherwise, patient will start having menopause-like symptoms. Clear to all of you? Next question. A 9-year-old girl presents for evaluation of regular vaginal bleeding. History reveals thelarchy, that is breast budding at 7 years, and adrenarchy at 8 years. Which of the following is the most common cause of this condition? So what is this condition in this female? See, normally the age of puberty in females is 10.5 years. And in males, it is 11.5 years. And the first sign of puberty in females is growth spurt. But growth spurt is not a visible sign, and that is why the first visible sign is thelarchy. Right? So thelarchy normally happens around 10.5 years of age. But in this patient, thelarchy is happening at 7 years of age. That means this is a case of precocious puberty. Precocious puberty means if at less than 8 years of age, female has breast budding. Males may precocious puberty means if signs of puberty, they start appearing at less than 9 years of age. In females, when the signs of puberty appear at less than 8 years of age, then that is precocious puberty. Now, normally when puberty happens at 10.5 years, then menarche happens around 12.5 years. There is generally a gap of 2 years between breast budding and between the onset of menstruation, right? So, if precocious puberty means appearance of breast budding at less than 8 years of age, then precocious menstruation means what? How do you define precocious menstruation? If menarche begins at less than 10 years of age. The most common reason for precocious puberty is idiopathic. We don't know. But the one very common reason which we know is that there can be CNS tumors. So, in all patients who come to you with precocious puberty, before you label them that they are idiopathic, you should always get an MRI brain done. But if they ask you what is the most common cause of precocious puberty, most common is idiopathic. It's only in 10 to 20% females that you get brain tumors which can lead to precocious puberty. What is the treatment for precocious puberty? You have to give them GnRH, that is continuous GnRH. Whenever you give GnRH in a continuous manner, it decreases the levels of estrogen, and so precocious puberty would be cured. Right? So, in this case, they are asking you what is the most common cause? The most common cause is idiopathic. Please do not say that it is tumors of CNS. Tumors of CNS is not the most common reason. Right? Idiopathic is the most common reason. Now, how do you define delayed puberty? If secondary sexual characteristics, they do not appear in a female by 13 years of age or in males by 14 years of age, then that is what is delayed puberty. Most common cause of delayed puberty is constitutional delay. Like precocious puberty is more common in females, constitutional delay is more common in boys. And how do you manage delayed puberty? For delayed puberty, I will have to give GnRH in a pulsatile manner. Whenever you give GnRH in a pulsatile manner, it releases estrogen. And whenever you give GnRH in a continuous manner, it decreases estrogen. Right? Next question. A 47-year-old female, G3 P3, complains of severe progressive menstrual cramps. So 47, and she's having pain in menstruation. So that is what is called as secondary dysmenorrhea. Right? Secondary dysmenorrhea is generally seen in females more than 30 years of age. She has heavy menstrual bleeding. Pelvic examination demonstrates a tender, diffusely enlarged 10 weeks uterus with no adnexal tenderness. Which of the following is the most likely diagnosis? So first tell me, is dysmenorrhea, secondary dysmenorrhea, a complaint of endometriosis? Yes, it's a complaint of endometriosis. Rather, the most common cause of secondary dysmenorrhea is endometriosis. But is this a case of endometriosis? No, because in endometriosis, endometrium is found outside the uterus. So in case of endometriosis, uterus size will be normal. It will be retroverted and you will get pain in the, there will be tenderness in adnexa. Why there will be tenderness in adnexa? Because of the chocolate cysts, there may be fullness and tenderness in adnexa. So because here uterus is enlarged, it cannot be a case of endometriosis, and over here there is no adnexal tenderness, so it cannot be a case of endometriosis. Then what about leiomyoma? That is a fibroid. In fibroid also the most common complaint is excessive bleeding. Here patient is saying that yes, heavy menstrual bleeding is present, and dysmenorrhea is also a complaint in fibroid, so she could be a case of fibroid. But is she a case of fibroid? No, because here what we are getting is a diffusely enlarged uterus, number one. And number two, we are getting tenderness in the uterus. So tender uterus and it is diffusely enlarged. In case of fibroid uterus, uterus will never be tender. Right? Uterus will not be tender and uterus will be irregularly enlarged. So wherever the fibroid will be present from that particular side, the uterus will be irregularly enlarged. Right? Then sarcoma. Uterine sarcoma is a very, very rare tumor, so it's not that. Now we are left with adenomyosis. Adenomyosis is a condition where endometrium is found inside the myometrium, and in this case, patient is going to complain to you of excessive bleeding because endometrium is present inside the myometrium and there is secondary dysmenorrhea. Apart from that, uterus is symmetrically enlarged. The size of the uterus is between 10 to 12 week size and uterus is tender. Tenderness of uterus in case of adenomyosis is what is called as Halban sign. Halban sign. Right? Investigation of choice in case of adenomyosis is MRI. Investigation of choice in case of fibroid is ultrasound. And investigation of choice in case of endometriosis is, tell me, laparoscopy. Right? So please remember this is a case of adenomyosis. And these three conditions are commonly confused. So please remember the discussion which I have just now told you. Next question. A mother brings her daughter in to see you for consultation. The daughter is 17 years old and has not started her period. And just now I told you delayed puberty is if secondary sexual characteristics do not appear by 13 years of age in a female. Now this female is 4 feet 10 inches tall and she has no breast budding. So she is a case of delayed puberty. On pelvic examination, she has no pubic hair. By per rectal examination, patient has a cervix and uterus. Why am I saying per rectal examination? Because in all virgin females, per vaginal examination is contraindicated. If I want to see whether uterus is present or not, I'm going to do a per rectal examination. Ovaries are not palpable. Uterus is present. As a workup, FSH and LH levels are drawn and both are high. Which of the following is the most likely reasons for delayed puberty in this patient? Now tell me. In case of let's talk about Mayer-Rokitansky-Kuster-Hauser syndrome first. In case of MRKH syndrome, which is Mullerian agenesis, is this a case of Mullerian agenesis? No, it cannot be. Why it cannot be? Because in Mullerian agenesis, uterus is absent. Right? In this case, uterus is present, number one. In case of Mullerian agenesis, ovaries are present, and because ovaries are present, estrogen levels are normal, and that is why secondary sexual characteristics are normal. Breast is normal. Right? So, in Mullerian agenesis, patient will have amenorrhea, but it will not be a case of delayed puberty. Her secondary sexual characteristics would be normal. So, it cannot be a case of Mullerian agenesis. Now, let's talk about testicular feminization. In testicular feminization, chromosome number is 46XY. In testicular feminization, again, uterus is absent. In testicular feminization syndrome or androgen insensitivity syndrome, breast development corresponds to Tanner stage 4 or 5. So breast development is proper. It is only the pubic hair development which corresponds to Tanner stage 1 and 2, but breast development will be very proper. In this case, breast development is absent. So again, it cannot be a case of testicular feminizing syndrome. Now let's talk about Kallmann syndrome. What is Kallmann syndrome? Kallmann syndrome is a condition in which GnRH is absent. So there is hypothalamic failure because of which GnRH is absent. Now if GnRH is absent, LH and FSH levels will be less, and because of this estrogen will be less. Right? And because estrogen will be less, that is why secondary sexual characteristics will be absent. That means breast development will be less, because breast development depends totally upon the levels of estrogen. Right? So secondary sexual characteristics are absent. That goes in favor of Kallmann. In Kallmann, uterus is normal and it is present. So here uterus is present. So that goes in favor of Kallmann. But what goes against Kallmann? In Kallmann, the levels of LH and FSH are decreased. Whereas in your question, they are saying the levels of LH and FSH are increased. Number one. Number two, in case of Kallmann, you will get normal stature. You will never get a female with short stature. Here you are getting a female with short stature. So this goes against Kallmann syndrome. Now last is gonadal dysgenesis. What is gonadal dysgenesis? Gonadal dysgenesis, a type of gonadal dysgenesis is Turner's syndrome. So whether I say gonadal dysgenesis or whether I say Turner syndrome, that's one and the same thing. Here the chromosome number is 45XO. Now, because chromosome number is 45XO, again, in this case, the gonads are streak. That means the ovaries are present, but they are not properly functioning, because of which estrogen is less. Now, because estrogen is less, the negative feedback on FSH is gone. All of you know that estrogen inhibits FSH. Now, because estrogen is less, the negative feedback on FSH will be gone. So, FSH will be increased. Because estrogen is less, so breast development will be less. Right? And uterus will be normal, and a characteristic of Turner syndrome is short stature. So here the patient's height will be small. So over here you are seeing that the patient is 4 feet 10 inches. Uterus is present. Ovaries are present, but she doesn't have a proper breast development. Pubic hair and axillary hair are also absent, and we are seeing that the FSH levels are high. So all this points towards Turner syndrome or gonadal dysgenesis as the diagnosis. If there are NEET PG students who are listening to me, NEET PG aspirants, all of you know that in gonadal dysgenesis there are various varieties. One of them is Turner syndrome. Others are a gonadal dysgenesis with XY karyotype, and with XY karyotype is called as Sewer syndrome, and XX karyotype is also there, right? But for all FMG students, please remember that gonadal dysgenesis is, you can interchangeably use gonadal dysgenesis term with Turner's syndrome. You do not need to know anything about Swyer's syndrome, right? Next question. During evaluation of infertility in a 25-year-old woman, a hysterosalpingogram showed evidence of Asherman syndrome. Which of the following symptoms would you expect this patient to have? So what is Asherman syndrome? Asherman syndrome is a condition in which endometrium is defective and there are intrauterine adhesions present. So there are two problems in Asherman syndrome. The endometrium is defective and there are intrauterine adhesions. Because endometrium is defective and thin, that is why the amount of bleeding will be less in Asherman syndrome in comparison to other conditions. Less bleeding is called as hypomenorrhea. Less bleeding is termed as hypomenorrhea or amenorrhea. So in patients of Asherman syndrome, either you get hypomenorrhea or you get amenorrhea, right? So amenorrhea, yes. Menometrorrhagia. What do you mean by menometrorrhagia? Menorrhagia means excessive bleeding. So menorrhagia means excessive bleeding. Metrorrhagia means irregular bleeding. So whenever a female has excessive bleeding at irregular intervals, that is what is menometrorrhagia. In Asherman syndrome, you will not get menometrorrhagia, you will not get menorrhagia, you will not get metrorrhagia. Menorrhagia is a complaint which is seen in case of fibroid. Metrorrhagia is a complaint which is seen in case of polyps. In case of Asherman syndrome, you will get hypomenorrhea or amenorrhea. One thing. Next thing is, what is the most common cause of Asherman syndrome? Most common cause of Asherman syndrome is curettage, which you do in a postpartum period. So excessive curettage, when you do it in postpartum period, that is the most common cause of Asherman syndrome. Apart from that, Asherman syndrome can happen because of excessive dilatation and curettage, or it can also happen because of genital TB. What is the investigation of choice in Asherman syndrome? It is hysteroscopy because it is diagnostic as well as therapeutic. On hysterosalpingogram, what is the typical appearance which you get in Asherman syndrome? You get a honeycomb appearance, right? How do you manage Asherman syndrome? You have to cut the adhesions by using a hysteroscope. So it is hysteroscopic adhesiolysis. Plus, you will have to insert an IUCD so that the adhesions do not form again, or you will have to insert a balloon catheter so that the adhesions do not happen again, and you will have to give estrogen and progesterone therapy to the patient because the endometrium is thin. I want to rebuild the endometrium, so I am going to give her estrogen and progesterone therapy. Right? So this is the complete management of Asherman syndrome. Clear? Next case. A 22-year-old woman consults you for treatment of hirsutism. She is obese, she has facial acne and hirsutism on her face and periolar regions. Her serum LH levels are 35 in milli international units and FSH is 9. So her LH levels are high, FSH levels are low. Androstenedione and testosterone levels are mildly elevated. Which of the following single agent is the most appropriate treatment for her condition? Now, in this case, patient has come to you with hirsutism. What is the most common cause of hirsutism? The most common cause of hirsutism in young females is PCOS or Steen-Leventhal syndrome. Right? Now, in case of Steen-Leventhal syndrome, patient is going to have two of the following three things. Number one, that is what is Rotterdam criteria. How do you diagnose PCOS? By Rotterdam criteria, in which number one is that there should be clinical features of hirsutism or the levels of androgens should be high. Number two is patient should have irregular cycles. Number three is on ultrasound, you should get polycystic ovaries. Out of these three, if any two are fulfilled, then that's a case of PCOS. But here they have not asked us the diagnosis. What they have asked us is, and we are not going to diagnose it also over here. Here they have simply asked us that a patient has come to you with hirsutism. What is the drug of choice? Now, whenever a patient comes to you with hirsutism, the drug of choice is oral contraceptive pills. Please remember that. Very, very important. Right? Now, I told you the most common cause of hirsutism is PCOS, but if hirsutism is of rapid onset, then in that case, the most common cause is androgen secreting tumors of the ovary. Or if along with hirsutism, you are getting clitoromegaly, features like clitoromegaly, features like increased muscle mass, features like hoarseness of voice. All these means that the levels of androgens are very, very high. And the levels of androgen which are very, very high, which show features of virilization. All these hirsutism, along with clitoromegaly, along with increased muscle mass, are together termed as virilization. So if you are getting virilization in a female, then it is not due to PCOS, then it is due to androgen secreting tumors of the ovary, right? But otherwise, the most common cause of hirsutism is PCOS, and the drug of choice for hirsutism always is OCPs, right? Oral combined pills. Next question. Achha, just one more thing before I proceed. Which drug can lead to hirsutism? Please remember, use of danazol in young females can lead to hirsutism, right? Now, a 29-year-old G0 comes to your office complaining of vaginal discharge for the past 2 weeks. The patient describes the discharge as thin in consistency, grayish-white in color. She has noticed a fishy odor, right? And she denies any vaginal or vulval pruritus, so there is no pruritus. She admits to being sexually active in the past but has not had intercourse in the past year. She denies she denies any history of sexually transmitted diseases. She is currently on no medications with the exception of her birth control pills. Last month she took a course of amoxicillin. On physical examination, vulva appears normal. Discharge is present at introitus. A copious thin whitish discharge is in vaginal vault. pH of the discharge is 5.5. Cervix is not inflamed, and wet smear indicates the presence of clue cells. So I know all after reading this entire big question, you know the answer, that the answer is bacterial vaginosis. Right, bacterial vaginosis. The pointers which are there which tell you that it is bacterial vaginosis: number 1, there is a grayish white discharge. Number 2, thinly coating vagina. Number 3, a fishy odor. Number 4, there is no pruritus. Number 5, the pH of the discharge is more than 4.5. And number 6, there are clue cells present. So what are clue cells? Clue cells are when the vaginal epithelial cells are studded with bacteria. That is clue cells. In case of bacterial vaginosis, because there is no inflammation, that is why there is no pruritus. Bacterial vaginosis is the most common cause of vaginitis in young reproductive age females, and it is not sexually transmitted, right? The treatment of choice in case of bacterial vaginosis is metronidazole, which you have to give 500 mg BD for 7 days. You can also use clindamycin, that is 300 mg BD for 7 days. The same treatment can be used in pregnant female also. In case of bacterial vaginosis, there is no need to treat the male partner. So treatment of male partner is not needed because it is not sexually transmitted. In case of candidiasis, patient's main complaint is not discharge. Patient's main complaint is pruritus. There is a lot of itching. Number 2, in case of candidiasis, there is curdy white discharge, right? There is a cottage cheese like discharge or curdy white discharge. Words like splash dysuria. So if they say that there is splash dysuria, that means it's a case of candidiasis. In candidiasis, when you are going to do a wet smear, you are going to see the fungal hyphae, and in this case, the pH of the discharge is less than 4.5. Candidiasis is the most common vaginitis which is seen during pregnancy with OCP use in immunocompromised patients, with steroid use, and in diabetic patients. Right? In case of candidiasis, it may be sexually transmitted, right? And here the treatment is fluconazole, 150 mg oral stat. But in pregnancy, we do not give oral azoles. In pregnancy, you have to give topical, that is miconazole or cotrimazole. Right? Then comes trichomonas. In trichomonas, you will get words like frothy yellowish green discharge, there will be pruritus, and there will be a typical appearance seen in vagina, which is called as strawberry vagina. Here again, the pH of the discharge is more than 4.5. So in bacterial vaginosis and in trichomonas, pH is more than 4.5. In candidiasis, pH is less than 4.5. In trichomonas, when you will do a wet smear, you will see something moving. So motility would be present. In trichomonas, it's a sexually transmitted disease. So you have to treat the male partner, and the treatment which you have to give again is metronidazole, 500 mg BD for 7 days, or you can give 2 grams stat. Same treatment has to be given during pregnancy also. Clear to all of you? Now, before I end this session, just one thing. So there are kits available in the government, in the PHCs, which you have to give if a patient comes to you with PID or if a patient comes to you with vaginal discharge. In case of vaginal discharge, the kit which you give is kit 2. Right? And this kit 2 has got tab fluconazole 150 mg and it has got tab secnidazole 2 grams. So kit 2 is given to any patient who comes to you with vaginal discharge. In case of PID, the kit which you give is kit number 6, which is yellow in color, which has got tab cefixime, tab metronidazole, and tab doxycycline. This you give to the patient, and to the partner you give kit number 2, which is gray in color, which has got tablet azithromycin and cefixime. Right? So in PID, to the patient, you are going to give a yellow colored kit, that is kit 6, and to the partner, you are going to give a gray color kit, which is kit number 1. And in case of vaginal discharge, you are going to give kit number 2. So these are some important questions which I wanted to discuss with you before you appear for your exam. But I just want that you give at least one day to OBGY, and in that one day, if you go through this session and go through all the other sessions which I have told you, it will be really very beneficial to you. Just have faith in yourself and go and give your exam. Do not leave any question because you don't have any negative marking. Make a smart, intelligent guess. That is the only advice which I have to give you. Take care. All the best.